Recording. All right, let's go ahead and take roll because we have a lot to cover tonight. Bless our hearts. Arian Palmer,
Arian Palmer,
Cameron Pierce, Cameron Lanford,
Cameron Lanford,
Charlotte McMahon, Krista Joby, Sierra Mitchell, Claire Kimichek, Cynthia Earhart, Dylan
Here.
Bell.
Go.
Who is here?
Dylan Bell,
Okay, Dylan Bell, Cynthia Earhart, Emily Burke.
I'm here. Cynthia's here.
Cynthia, we don't know who I'm is. Emily Burke, Faith Pinkney, Jen Hernandez, Juckett, Kelsey,
Juckett Salem,
Kelsey Hearing,
Leslie Williamson, Maddie Doyle is here, Leslie Williamson, Mitchell Hinton, Nicole Tenorello, Noah Wilson, Ryan Jackson, Sarah Coker, who has earned the right to reduced stars. I'll leave 2. Vishnu Gudavada and Wilson Maddox.
Vishnu Gudavada.
Wilson Maddox. Okay, I have Ariane, Cameron, Charlotte, Cynthia, Jen, Bang, Kelsey, Maddie, and Vishnu. That's it. If someone else comes in, let me know. You guys know, but just making sure, we are ending module trauma and we are entering special populations. I don't know if you feel it, but I feel it. We are in the last 2 weeks of this class. Congratulations to every one of you for having done the work you've done to make it to this point. I'm very proud of you, and I am scared to death that it has flown by, and you guys are about to go spread your little wings and do your little EMT flying, and I'm excited for you, and I'm proud of you, so make sure you continue working hard. These last 2 modules are entire sections of the National Registry exam. So there's a lot of material covered in each one of these modules that will both be learned over 1 week in the course. So tonight we will cover 4 chapters. We will cover obstetrics and neonate, which is huge. We'll cover pediatric, geriatric, and special challenge patients like those who are home ventilated or those who have home caretakers for special conditions. Big module. Make sure that you are doing the work this week. You have 4 chapters to read. Please do read them. The information this week is granular. So you are going to see a lot more test questions on the minute details of the chapters. So please give it extra attention. The trauma module is really pretty simple. Everyone loves trauma. But we are back to a module that's pretty difficult. And so please give it your attention. We will take module exam trauma this week, Wednesday and Thursday. This evening, before I go to bed, I will double check all grades on quizzes. I will double check the completion of all week work from last week. If all is kosher, I will release the quizzes for you to continue your practice on trauma-related quizzes up to the point of the exam on Wednesday. I'm going to cut them off at 5 p.m. on Wednesday. So if you have questions about that, let me know. If you have feedback about that, positive, negative, let me know so that I can try to find whatever testing modality will help you best. And I think you guys really liked the quizzes being open last time, and so we're going to do that again. Any questions for me before we begin with obstetrics and neonatal? All right, take about 2 minutes to grab yourself something to drink, and I'm going to load the slides up. We'll be loaded and ready to go by 6:13.
No, I knew that. Yeah, all the slides are like gold. Like they crush a bunch of words together. Like I did them. And I was like, this class is so stupid. Notes literally tell you nothing. Like I learned nothing from this class.
I knew that was going to happen. All right. We will begin with obstetrics and neonatal care. As I said, this is a pretty big chapter. We're talking about delivering babies. We're talking about the care of mom before that point. And we're talking about what to do with neonates once they are born. So that's a lot of information. And most of this information will be brand new to you and not anything we've touched on kind of before. So please take caution and care when you're reading this chapter. We're going to talk about the things I said. In order to understand this chapter, very much so, you must understand the female anatomy. And you must understand fetal development anatomy that is discussed within the chapter. So make sure you are reading the chapter. We're going to discuss the fact that almost all deliveries encountered by EMS are indeed, quote, normal deliveries, which means that things go well. Almost all of them go well. We're going to discuss in this chapter that the mom delivers the baby. We're simply there, as all the other parties tend to be, to coach and cheer on this mama, doing the magic that mamas do and have done for hundreds of years, long before a bunch of men, mostly Caucasian but irrelevant, got together and decided what normal delivery should look like. We're going to talk about good things about that. We're going to talk about bad things about that, like the fact that the United States of America has one of the highest fetal mortality rates of any modern country in the world. And we're going to talk about why. So know that deliveries are normal. They occur. And they would be occurring without you. That's, I think, comforting to the provider to know that this is normal and that it would be occurring whether you were there or not. And so our job is there to coach on and cheer on that mama in doing good things for delivery. And then there will be abnormal ones. And almost all of those will be situations, every one of those will be situations from the EMT perspective that are load and go. The EMT, nor does the medic, want to get into a scenario of complex or difficult delivery. So we'll talk about what each one of these are, and we will talk about the fact over and over again that all these are... He did the same thing with his leash. Get him. All of these are load and go scenarios. Nuchal means neck, and it's one of the most dangerous things that we can find during the delivery of a baby in the EMS setting. It means the cord is wrapped around the baby's neck, and if this is not resolved, then the child is very much so going to die or sustain an anoxic injury. When you think about cerebral palsy, when you think about mental retardation, a lot of those children are secondary to difficult delivery or atypical delivery, where oxygenation to the brain is prevented due to a multitude of reasons, all of which result in the child either passing away or not being what they would have been otherwise. So we've got to prevent scenarios where oxygen is reduced to the brain of a child. And there are BLS versions of those, and there are ALS versions of those. And nuchal cord is arguably a very BLS emergency, meaning that you can do small things that make a very big difference, like just simply getting the cord and unraveling it from around the baby's neck. So we'll talk about that. Prolapsed cord worries us because it tends to suggest that we will be a nuchal cord. Prolapsed cord means that the first thing you see in the vagina presentation for delivery is the cord instead of the baby's head. You're going to come to know that the baby's head should present first, nothing else. And so for the cord to be out first is very concerning because my worry is that as the child progresses down the vaginal canal for the purpose of delivery, that the cord will then become nuchal. Remembering that nuchal is neck. Nuchal is neck. I'm going to put my phone on silent because it's not going to stop. The moment I lecture, the EMS gods know it, and so they immediately start killing off people so that I'll pay attention to my phone. But I'm going to put it on silence, so ha-ha to them. And I'll pay for that later, about 2 a.m., I would imagine. Breech delivery is anything else presenting before the head of the baby. So I remind you that the head of the baby should present first. And in breech delivery, maybe you get an arm first. Well, that's not good. Or you get a leg first. That's even worse. We should have the baby upside down. They should present head first, then shoulders, then thorax, then belly, then pelvis, then legs, obviously. That's how it should progress. And so if you see anything else delivering first, then that would be breech delivery. We'll talk about the trimesters of pregnancy. There are 3 of them, obviously. That's why they're called trimesters. Well, one of the reasons. And they're called trimesters because they tend to last approximately 3 months, although we're going to come to know pregnancy in weeks, not months. So in the 3rd trimester, which is the last trimester, you have 2 common emergencies. Yes. 2 common presenting illnesses that might become emergencies. So one of the 2 of these, placenta previa, is pretty mild. It typically is diagnosed throughout the pregnancy. It can be very dangerous, but typically with modern management, we can deal with placenta previa. Hold on. Hey, I'm lecturing. Everything okay? Hey, I'm lecturing. Everything okay? Okay, I will. My apologies. So placenta previa, again, is the lesser of the 2. And placenta previa literally means that the placenta has not all the way attached to the uterine wall, and it is not attached in the correct place. The placenta should attach towards the top of the uterus, which, if you don't know, is going towards mama's head. And so when it doesn't, it can kind of migrate down the uterine wall, and it can start bleeding a little bit and getting in the way of things. And so normally that means let's put mom on bed rest. Let's keep mom very mild in her motor functions, and let's watch our diet and make sure we're not doing anything that would increase blood pressure. And then the baby can be taken out when fully developed at the 40-week mark or earlier, depending on the pregnancy, via cesarean. So you might get a 911 call in the 3rd trimester of spotting. They complain of spotting. So what is spotting? It's little bits of bleeding here and there, which can be somewhat normal, but in the late trimesters, maybe not so much so. And so if you told me that a late trimester pregnancy, especially one that's kind of high risk, like someone that has had blood pressure problems throughout the pregnancy, or someone who has had diabetic problems throughout the pregnancy, if they are now getting spotting, bleeding in the 3rd trimester, it would concern me for placenta previa. We'll take the patient in, they'll do an ultrasound and further testing. They'll confirm that it is indeed that. They'll manage the patient as necessary depending on the development of the fetus. Most of that would be manageable. So placenta previa is bleeding due to the placenta not fully attaching to the uterine wall and not fully attaching to the uterine wall in the correct place. It can migrate even down to the top opening of the cervix, which would prevent the pregnancy from being able to deliver vaginally. And so again, you're not going to get much out of this if you don't have any idea about the female anatomy, which we have said is a requirement before. And so hopefully you took that to heart then, and you did a little time. We know that the cervix is the gatekeeper to the uterus. If you begin into the vagina and you go all the way up the vagina to the next part of anatomy, it would be the cervix. and the cervix is the gatekeeper that protects the uterus. And so the placenta in the Previa patient could actually block the cervix so that you couldn't possibly deliver vaginally, and that would result in a cesarean. Again, pretty mild. The thing to take away here is that it doesn't typically come with pain. Bleeding is the primary symptom, and it doesn't typically come with pain, and it occurs in the 3rd trimester. That would be placenta previa. You are going to see questions on placenta previa. The latter on the slide, abruptio, placental abruptio, is very bad, and it most likely will result in the mortality of the fetus. It also has a high mortality chance of mom. Placenta abruptio is when the placenta emergently detaches from the uterine wall. Obviously, this causes a lot of bleeding. It would immediately rob the fetus of nutrients, and it would become anoxic and die. Mom would potentially then die from the internal bleeding. Placental abruptio is common of trauma, intentional and unintentional. So if you imagine a 3rd trimester mom, big belly, riding in the driver's seat, which they shouldn't be doing, but they're in the driver's seat, they're wearing their seatbelt properly, they're very close to the steering wheel for whatever reason, and they get into a significant motor vehicle accident, and the airbag deploys and hits mom directly in the belly. That could result in placental abruptio, and so then we don't prefer moms to ride in the front of a car in their 3rd trimester for that reason. So abruptio is bad, and the baby will likely die, and mom very well could as well. This is why we take great care and caution when pregnant folks have been exposed to trauma. You need that ultrasound to know if there's a problem. And so even if the trauma was mild and minor, we would suggest this person go get checked out and make sure that there are no gross and obvious signs of abruptio that might lead to the loss of the pregnancy and potentially the loss of mama. Spontaneous abortion is exactly what it says. Up to about the 20-week mark, the baby can spontaneously abort. Mama's bodies know if they should keep babies a lot of the time. And so up until about the 20-week mark, they can abort. This is why in the old days, no one was ever told about a pregnancy until after the 20-week mark, because in those days, being able to produce a child for your husband was a big deal. And the hope was that that would be a boy even. And so for a pregnancy to spontaneously abort might suggest that this particular spouse isn't going to carry to term. And there was a lot of negative connotation on that. And so even today, we find some families that will not speak of a known pregnancy until after the 20 or 25-week mark. The reason being is that the body hasn't made a decision yet as to whether the pregnancy should be carried to term. Is this a healthy pregnancy? And if the body were to decide that it shouldn't, so you took a pregnancy test at the 8-week mark and the baby shows positive on these very capable and early pregnancy tests, these urine-based pregnancy tests, beta HCG, and it shows that you're pregnant around the 8-week mark, and so you're so happy and you carry on, and about the 17th week mark, there's this rush of contraction in the belly, and then that is followed by a good bit of vaginal bleeding. There's a good chance that that might be a spontaneous abortion, better known by laymen as miscarriage. So there's a little bit of information about that. If we were called in the very early trimesters of a pregnancy and this was the complaint set, this would be one of my field impressions. Ectopic pregnancy we have discussed already, and that's when the pregnancy attempts to develop in the fallopian tube or outside of the uterus anywhere. Obviously, there's not enough room for that to occur, and so it would burst and it would begin bleeding and likely put mom's life in emergent and grave danger. So any childbearing age female complaining of lower level abdominal pain should be considered for ectopic pregnancy. If you go to a 22-year-old young lady and she is diaphoretic and pale in fetal position with sudden onset lower abdominal pain, and this person is tachycardic, tachypnic, they look sick as crap, I would absolutely include in my questions, could you be pregnant? Are you sexually active? Are you on birth control? Even if you are on birth control, there's a very small chance that you could get pregnant. So these are the questions you should ask. And if the potential for pregnancy exists, then ectopic pregnancy must be on your differentials. It must be on your field impression list. I would also ask, of course, if they have their appendix, because appendicitis presents very similarly. But one would be diffuse and in the lower abdomen, and one would be in the right side of the lower abdomen with dull pain. The appendix obviously being in the right side, and ectopic pregnancy can vary based on which fallopian tube are we dealing with. Is it even in the fallopian tube? Is this diffuse or is it isolated? Is it acute? So that's ectopic pregnancy. We've talked about that before. In the trimesters of development, again, we have 3 of them. And so in the first, second, and third trimester, we're worried about the bottom 2 on this slide. And we're also worried about diabetes in pregnancy. So pregnancy is called gestation, and gestation eclampsia, preeclampsia is a big concern for us, and gestational diabetes is a big concern for us. You're going to see test questions that say what differentiates preeclampsia from eclampsia. Preeclampsia is simply unstable high blood pressure during pregnancy. Eclampsia is when that unstable high blood pressure becomes a seizure in the presence of a pregnancy, especially in the second and third trimester of the pregnancy. So preeclampsia is high blood pressure in pregnancy that's unstable. Eclampsia is when that blood pressure becomes a seizure. So preeclampsia is the cause and eclampsia is the result. The management of this is the same for you as it is with any other seizure patient. Manage airway, airway, airway. When patients seize, they do not effectively breathe. They also foul up their airway with secretions like thick saliva. If you want to manage a pregnant seizing patient well, you need to put them on their left side, and you need to suction, maintain an open and oxygenated airway. That is the treatment set for a seizing pregnant mom or a seizure in general. I asked the class a very important question. Why is it important to place mom on her left side? Why is it important to place late trimester pregnancies on their left side? Very good, Cynthia. I'd like for you to be a little more specific, but yes, you're correct. Very good. Let's see what the other students have. 100% Wilson. The vena cava runs underneath and central the lungs and heart. Its job is to return deoxygenated blood, so bad blood, back to the heart so that it can be oxygenated. When you are third trimester pregnant and you are at least half more your weight, that big baby can rest on top of the vena cava and prevent blood from returning to the heart. This is called supine hypotension or tensive syndrome. You need to know that. We do not ever place the unconscious late trimester mom on her back if we can ever prevent it, because it is likely that we will reduce blood pressure by tamponading the vena cava. We remember that the word tamponade means to compress, constrict, restrict the normal mechanical function of an organ. And so if you were to squeeze the vena cava slow and closed, you would reduce, if not cease, blood return to the heart. That would result in low blood pressure, it would result in a change of mental status, and it would result in eventually, if not corrected, potentially the death of mom. And of course then baby. So, big deal if you have an eclamptic mom to turn them on their left side, suction airway, and oxygenate that airway. In general, people tend to really worry about whether or not they're taking good care of the baby. The EMS rule of thumb is that if you're taking good care of mama, then you're taking good care of baby. Typically speaking, EMS providers in the 911 world do not have tachometry. You are not monitoring the fetal heart rate and measuring the fetal heart rate against the uterine muscle behavior. So then you don't really know how the fetus is doing. So the general rule of thumb to comfort us is almost always, statistically speaking, if you take good care of mama's ABCs, keep mama's perfusion happy, you keep the baby happy. So there's that. Once we do deliver that baby, we're going to talk about how to take care of what will most likely be a fresh, beautiful, angry little nugget who's doing great. Most of them are doing great. About 10% or less of newborns will require some amount of resuscitation. Even smaller number than that will require aggressive resuscitation. And a large number of those that do are babies that could have been predicted as potentially arriving in compromise. As we go through this chapter, we're going to discuss how your sample and OPQRST of that mom is going to dictate your comfort level with that baby. Should I be delivering this in the field? The answer to that will often be made by your physical exam of mom and your sample and OPQRST. If during the sample and OPQRST of this pregnancy you find that it was high risk, there's drugs or alcohol involved, there is pre-eclampsia or previous eclampsia events, there is gestational diabetes, if you find out that mom has had multiple failed pregnancies, spontaneous aborted pregnancies, these things would all lend me to not want to deliver that baby in the field. So, it's crucial that in our sample and OPQRST we find a few things. Number one, who is your OB physician? Have you been under prenatal care? Is there a physician taking care of this pregnancy? Who is that? What have they told you? How have the checkups been going? How has fetal development been going? Are you taking the prenatal vitamins? Have you been smoking and drinking? Are you on alcohol? Have you been doing any municipal drugs, any street drugs? Are you taking any significant prescription medications or herbal supplements? Another thing we really want to know to predict whether this newborn arrival will be normal or require an amount of resuscitation is para and gravita. Para and gravita allow us to judge this pregnancy as compared to those previous pregnancies. I like to remember gravita. It's the pregnancy count, by the way. pregnancy count. I like to remember gravida because as the baby develops, the end goal of this thing, this pregnancy's goal, is to come out. And it does so with gravity. There's uterine contraction, of course, but moving down the chute is the way out of this thing for this beautiful brand new baby. So gravida equals how many pregnancies have you had? Para sounds like parent. How many of those pregnancies resulted in babies you're the parent of? The actual definition of para is how many of those pregnancies resulted in live birth. They were born, and when they were born, they were alive. So, normal gravida para would be if I am the mom of 2 little ones, and I'm currently pregnant, then my G is 3, and I am P2. So you'll hear us say all the time, hey, this is G2P1. You'll hear us say that all the time. Why does that matter? Here you go. That's why that matters. If this is G1P0, labor can take more than a day. If you get called to the house of this sweet, sweet mom who's brand new, young, military spouse, and I'm making this story up because I've seen it a couple times. Military spouse is at work and I'm having contractions and my water broke. And they call 911 because that's scary. A lot of people have forgotten that we can deliver these babies naturally without the help of a doctor. So we've got this first pregnancy that's now trying to deliver. You got a long time, typically speaking. So Cynthia says she didn't really get a long time, but most people get a long time. Cynthia, how many hours did you labor for your G1? On average, you're going to be looking at 3 hours to somewhere around the 24-hour mark for the labor time of the first pregnancy. So there you go, Cynthia. 11 and a half hours you labored with the first pregnancy. And so people tend to get a little spun up when they hear they're in labor. Well, what's the G number? What's the P number? If the G number is low and the P number is 0, you got time on your side. Here's the other side of that coin, though. If you go to G5, P4, you better get your catching mitt ready because that baby is coming out of a pregnant mom whose body has learned this mechanism. Every time this beautiful mama has a new baby, that body has learned the process, and they will squirt those little babies right out in a matter of no time. The book will call that a lightning delivery. A lightning delivery. That's what the book will call that. So not only does G and P help you predict the outcome of this delivery, but it also tells you how fast you're going to be. So in Leslie's case, her G1 delivery was pretty quick for the statistic. But on general speaking terms, you've got time. Now that has a lot of other things. High risk, was it? High blood pressure, did you? Were you on any drugs or alcohol? Do you have any familial history of fast pregnancies? All kinds of stuff like that. But on general, the first one, we've got time. As that mom goes up in P and goes up in G, then you're going to deliver much more quickly. So keep that in mind. We'll talk more about what it is to take care of these babies and if what is needed, if needed, for resuscitation. Again, most of these deliveries take place all by themselves. We've already learned how pregnancy occurs because we did that in the GYN chapter of the medical world. So I'm going to leave that alone for now. You can review it on your own. You can see that the good placenta should be up here, attached to the superior wall of the uterus. And then the cord drips down and plugs into baby around the umbilicus and is supplying the baby with both arterial and venous blood flow. And in doing so, is providing all the nutrition that little baby needs, which is just so beautiful. And you can see that the head of this baby is resting up against the cervix, which is the gatekeeper. And if the cervix were to dilate to 10 centimeters and it was to efface itself, meaning to thin itself out and become very open, then the baby would progress down the track and eventually out the vagina. That would be the hope. So familiarize yourself with this knowledge. There's a particular anatomy on the slide that you need to pay attention to. That is the fundus, where you see the hand and red dot. The fundus is the top part of the uterus. You can think of the fundus as being the strongest muscle in the uterine wall, and its job is to squeeze the crap out of the uterus when it's time to deliver this baby and get this thing out of here. We can feel the fundus. It is the most firm part of the uterus, and it is the most superior part of the uterus. As the baby develops, the fundus moves up the mother's anatomy. Later on, we're going to come to know that if mom doesn't stop bleeding quick enough after delivery, we can massage the fundus and help mom stop the bleeding process. So take note of the fundus now. Moving on, the vagina is off clearly where the mom is going to deliver. Okay, this is a little bit of a different placental attachment here, and if it weren't attached fully, that would be called placenta previa. And if it moves itself down into a dangerous space, that would be a higher grade of placenta previa. So make sure we remember that placenta previa is the inappropriate attachment of the uterus and the placenta together. And it moves down to a bad place. It causes bleeding in the third trimester with no pain, typically. I'll let you read what it delivers. It carries in the fetal sac about 1,000 cc's of fluid. That fluid is typically kind of clear yellow, but if you saw the fluid and it was brown in there, that is called meconium staining. Meconium is when the fetus gets into distress and actually poops in the amniotic fluid. That raises the stakes of a delivery, and a good number, not a lot, less than what we used to think, of those babies who present with meconium staining require additional resuscitation than those who did not. So it's not a good finding. So this should be very clear. It should be see-through. It should be just maybe yellow tinge. If we saw it brown or it had thickness to it, I'd be concerned. And if that was on the baby, if the baby comes out with this kind of brownish stickiness, that would be meconium. And meconium is baby poop. And it would typically mean, not typically, that's not correct. It would sometimes mean that the baby will require additional respiratory support. That would have also gotten into their airway tract. And so that might cause additional trouble. We'll talk about that a little bit more. Here's the normal changes in pregnancy. You're going to see a couple test questions about that. Basically letting you know that all vital sign in mom goes up during pregnancy and continues to increase through the third trimester. Why is that important to us? Well, if the patient has been in some type of shock event, they're always a little higher in blood pressure. They're always a little higher in heart rate. They're always a little higher in respiratory rate. You might miss it because you're looking for the patient to be in 12 to 20. Well, they rest normally at 24. So what's normal for them? is not going to be normal for a non-pregnant person. What does that mean to you? We get a little complacent. And so we think, oh, well, they're not bleeding to death. That's just because they're pregnant. And pregnant people have higher vital signs. Well, you don't know that. It's hard to tell between one versus the other. So again, I say to you, high index of suspicion. Any concern, let's just go get checked out. Heart rate increases by 20%. Blood volume increases. Make sure you pay attention to that when you're reading. Obviously, as the baby develops, it displaces mom's anatomy, causing a ton of things. Vomiting in the first trimester, heartburn, bloating feeling. They're never comfortable. They hate it. Some people, not everybody. But it's quite annoying, all of these changes in this mama, and there's not enough room for everything. So sometimes they feel like they can't breathe, sometimes they feel like they can't get a breath, sometimes they feel like they have chest pain. There's a lot of anatomical change that's going on. We already talked about diabetes in the presence of a pregnancy. We talked about preeclampsia and eclampsia. We talked about ectopic pregnancy being any pregnancy that develops outside of the uterus. That would be considered ectopic, and it is very dangerous. If it were to develop outside of the uterus and result in a rupture, it would bleed, and that would be a surgical emergency, so pay attention to that. Typically, we consider spontaneously aborting to be a passing of the developed fetus before the 20-week mark. We already discussed that. Abuse is something we're always looking for with mothers. Physical abuse, that will be in part of your interview for sample and OPQRST. Substance abuse and alcohol abuse are always on our radar because those substances prevent the normal development of a fetus. If I expect XYZ development at the 30-week mark, I simply cannot apply that to a fetus that has been exposed to alcohol and drugs. As you can see on the slide here, it results in growth restriction to fetal development. Remember, you can't put late trimester moms on their back. So say you're going to place this patient in spine motion restriction. Well, you might have to use a KED. Okay? You might not be able to use a spine board, or if you're going to use a spine board, the least you can do is put mama's tilt in. So put mama on your stretcher with a spine board, but put the spine board tilted ever so to the left to keep that mama safe. Well, here's your KD. It lets you protect someone's spine while they are able to be positioned in, say, semi-Fowlers. If you can sit mom up at all, then the problem of putting them on their left side goes away. These are all the uses of the KD. It's a freaking amazing device. This one's being used as a leg splint. It can be used as a tourniquet for the pelvis, or it can be used as a pelvic binder. And here's how you could put mom in spine motion restriction with a KD without having to lay mom flat. Now, this is obviously in a car, and I want you to ignore that because we would not typically use it for a car. But this device can be applied and spine can be protected without having to keep that mama flat. If mama's got to be flat on her back, I have got to find a way to tilt it to the left or be able to roll mom into the recovery position to the left. Okay? So keep those things in mind again. Overall blood volume increases, heart rate increases. In cardiac arrest of a mama, compressions need to be provided while you are accounting for that left-sided tilt. What does that mean? Put mama on a backboard. Strap the backboard to mama. Turn the backboard at least 25-30 degrees to the left. And then put some bags that aren't necessary underneath it to keep it there. Then perform compressions as usual, accounting for the patient's vena cava. The other thing the book says you can do is manually displace the uterus, meaning that someone physically pushes gently on the right side of the uterus, gently pushing it towards the left, getting it off of the vena cava. The better thing to do here would be to have a CPR device that would allow you to turn the patient. So I bring you the Lucas. The Lucas device will do CPR no matter what. I bring you the Autopulse. Now I have my preference, but it doesn't matter what my preference is. These devices allow CPR to continue while the patient is gently ever so to the left. Okay? In this particular one's case, you see this band action here where the head is here and the chest is under the band, and you could turn that sideways and it would still do its job. So those are options for CPR in the pregnant mama, which I hope you never have to do. I'll let you read the cultural sensitivities. I'll let you read the teenage pregnancy part. Those are good things, but they are not super important to this lecture, so I'm going to carry on. We already talked about how to get a good sample in OPQRST on these people. We've talked about what questions to ask. This particular slide here is HELA test question. HELA test question. They're going to ask you, what stage of labor is blank? Stage 1 begins when you dilate the gatekeeper to the uterus, also known as the cervix. When the cervix is fully dilated and the baby begins to present, we are now in stage 2, the beginning of stage 2. So the stage 1 ends with head presenting. We hope the head first, okay? We hope. Stage 2 begins with the head presenting and ends with baby is out. Stage 2 ends with baby out. 3 begins with the baby out and ends with the delivery of the placenta. Guys, you got to remember that it ain't just the baby that's got to be delivered. About 10 minutes later, up to like 15, the placenta's coming too. And that makes sense because the baby was hooked to it when it came out. So the stages of labor are super important. Okay, so here we are talking about delivering this baby. Everything we've done thus far is discussed how to predict the outcome, how to interview mom for sample and OPQRST, what things are important. So now we've gotten to the point where, okay, we're going to deliver this thing in the field. Beginning that conversation with knowing the stages of labor. Okay? Here's your first stage. Contractions begin, and we expect true labor. This is a test question. We expect true labor for contractions to get more in strength and less in duration. So they get stronger and they start occurring more frequently. And the duration of those contractions, we are going to monitor. It's going to tell you by definition here about Braxton Hicks. That's what's on the screen. Now, I don't mind you knowing about Braxton Hicks because the book thinks you should, but I do want to make this statement to you. It is not our job to truly say whether Braxton Hicks is what we're looking at here or whether we're looking at true labor. If a person is believed to potentially be in labor, go to the hospital. Let a physician make this call. Never suggest to a patient that they are experiencing Braxton Hicks versus true labor. Never, ever suggest that. But you should know the difference. Braxton Hicks contractions are not measurable. They do not follow a pattern. They tend to be all over the place. With true labor, we started out with a very light contraction that was a short duration, and then in 10, 15, 20 minutes, 30 minutes, 40 minutes, we have another one. I would expect them to increase in strength. I would expect them to increase in duration. And I would expect them to become more frequent. So by the time you get to a contraction that lasts for 30 seconds and is occurring every 3 minutes, you better get ready to catch, because that's a baby that's coming. I hope you understand the deal there. If not, let me know. Second stage is we're going to deliver that baby, which will most likely go well. Baby comes out. We're going to clamp the baby's cord after about 10 minutes. There is no urge. There is no reason to rush the process of cord clamping. There is a significant amount of data to suggest at the end of stage 2, when the baby has delivered, that we should not put any focus on cord cutting until such a time as the cord has stopped pulsating or we're at the 10-minute mark. Babies who have their cord prematurely cut have more chance of hypotension, hypothermia, hypoglycemia. I hope you're seeing a pattern. Those kids don't do as well. So then we don't need to cord cut. Everything that's in that placenta that can go to baby needs to go to baby before we cut the cord. So it's at the 10-minute mark. The cord has stopped pulsating. We're going to cut the cord. Now, hopefully, whoever is the parent of this kid, mom, dad, the other dad, grandma, grandpa, the pastor, whoever the hell they come up with, and they are elaborate and creative, may want to cut the cord. So great, that's great. We're going to break out our OB kit. We're going to place a cord clamp about a few inches from the cord where the baby connects. And then you're going to do a couple inches from that clamp. So cut in the middle. Pretty easy. Later on in the slide, it's going to tell us exactly how far it wants us to go. But I want to talk about that in reality. Paramedics and nurses and doctors, if the baby requires any amount of fluid resuscitation, blood products, sugar products, medications, we can give those things through the cord. If you gave us enough cord to work with. So the takeaway here is, if you cut the cord too close to the baby, number one, there's going to be bleeding concern. And number two, you're going to reduce the amount of cord that's usable for UVC, umbilical cord vascular access, where we are going to actually give the baby medications and fluids and products through the cord. So don't cut the cord too close to the baby. You need to be somewhere around 3 to 7 inches away from baby so that we have enough cord. The book will give you a specific number. Pay attention to it, but that's the talk. That's the takeaway. Is later on, say the baby needs some fluid on day 2. Say the baby kind of isn't coming around very well on day 2. We might cut the top tip of the cord off and use that fresh vasculature underneath there to give the baby medications and fluids. And so you don't want to have cut it so short that we can't cut down and get to the good stuff. In the third stage, up to about 30 minutes, they say, you're going to get the placenta. It's important to take a look at the placenta and look that it looks like it should. And by that, I mean, it's an ugly little thing. But are there any ripped edges? Like, does it look like it has trauma to it? Because if it does, that may require bleeding control inside of mama. It increases mama's chance of postpartum hemorrhage. We don't want that, and so you do want to have an eyeball on that placenta and make sure if there is any obvious trauma that we've made the receiving ALS backup or the receiving facility aware that we have found such, because that increases mama's chance of postpartum hemorrhage. Again, break out your OB kit. There's pictures of the OB kit in here. It's got lots of fluid catchers in it, and boy, are you going to need them. So if you got towels around, great. If you got blankets around, great. I'm going to tell you right now, babies coming out of vaginas are slippery little suckers. You will drop that kid so fast. And I'm going to tell you, if you thought holding on to that kid on the stretcher was difficult, imagine trying to get that slippery little sucker out from the wall and the stretcher. Because there's a hole right by the stretcher where that baby will slip right down into. And now you're trying to explain to mama why you're digging their baby out from the floor of the ambulance. That's a tough conversation to have, folks. So hold on to this slippery little sucker because it'll fall right out of your hands. And now you got a lot of making up to do. Careful with that. You can help your chances by getting out a bunch of towels. Get out a bunch of blankets from the ambulance or from the house, depending. And get yourself in a scenario where all that slimy, nasty mess isn't running free. I also want to talk now about when we must stop trying to go to the hospital and let's just deliver. The rule of thumb typically is that once the baby is physically presenting, that's it. Stop trying to go to the hospital. Stop the ambulance. Stop trying to package for transport. And let's prepare to deliver. Because you're not going to keep this baby from coming. It's coming. So the rule of thumb is if the baby is physically presenting, then we need to just prepare to deliver. The caveat to that is if you see a condition in which you should not deliver. Now, you can't stop delivery from occurring, but you can encourage mama not to push, which is going to be very difficult. Say you presented with a prolapse cord. Say you presented with a nuchal cord and you can't get it over the baby's head. You would not want that mama to push anymore. You'd want to stop trying to deliver, get on a stretcher, and get your butt to a hospital because that baby is in minutes of trouble from not being able to perfuse their brain. Arm delivers, leg delivers first. All of those are reasons to stop pushing mama if possible, and that's not easy. That ain't even very possible. So that's what we would do if we had to. So if you present and it looks good, heads out first, and I'm not super concerned. I'm not grossly concerned about drugs and alcohol. I'm not grossly concerned about high-risk pregnancy. Then prepare to deliver. Stop trying to transport. Here's your OB kit. Look at this little bulb syringe here. Okay? Test question. Test question. With this bulb syringe, do all babies need to be suctioned? No. All babies do not need suctioning. But if they don't come out screaming and hollering and kicking and slapping people, then they do need suctioning. The suctioning will stimulate this baby to breathe on their own. However, neonates are nasally obligated. They can only breathe through their nose. They cannot breathe through their mouth. They do not know how to breathe through their mouth. So you must suction the mouth first, because if you breathe through your nose and something stimulates your nose, what do? You take a breath. You don't want them to suck that stuff in their nose into their lungs because you stimulated it first. So we're going to suction the mouth before we suction the nose. The way I remember that is M comes before N on the alphabet. Mouth comes before nose on the alphabet. So suction the baby only if they require it. And if they do require it, mouth before nose. That's a test question. This little yellow crappy dappy here is a clamp. Put one clamp about 3 inches up from the baby. Put the next clamp about a few inches from that clamp. And then snip in the middle. I didn't tell you this, but a good pair of trauma shears will hella cut a cord. Now, I didn't tell you that, and I'll deny having said it on this recorded lecture. However, they provide this sterile scalpel here, a number 7 or a number 10, and that baby is sharp. I can't tell you how many people are better at cutting off their own finger than they are at cutting a cord from a baby with a scalpel. That is a spongy little sucker. I can't even explain to you the texture of a freaking in this case, not nuchal, umbilical cord. Weird little thing. So, I suggest you take one of these sterile dressings, put the cord down on the sterile dressing, and cut the cord going down onto the stable underneath. Don't try to cut the cord in the air. And don't try to cut the cord around your hand. You people are crazy. And every single time you go flying your blood everywhere. And I'm going to laugh at you. I'll do the right paperwork and we'll get you taken care of. But it's going to be funny. And potentially, you're going to get yourself exposed because you got all that baby gook on you. So, careful cutting the cord. Hilarious, in my opinion. Put it down. Elevate the hips about 2 to 4 inches. That is such an important component. Put a blanket underneath the butt of mama. She ain't gonna like it, and I don't care. It'll help, and she'll like it once she realizes that it helps. It pushes the pelvis up and opens up the gate. So put a little something underneath mama's hips, underneath her butt bone. Elevate her up a little bit. And then you're going to bring the head and neck and upper back. Get the semi-Fowler's approach going. Okay? There's a picture in here of this. And then you want to kind of bring your legs of mama kind of up towards the head. Again, there's a picture of this. There you go. Once you get to this state, ladies and gentlemen, it's time to deliver. You can't keep the baby from coming. You can try. You might even need to try based on what we've talked about, but it's going to be difficult. If mama gets into any trouble, put a non-rebreather on her. Guys, generally, mamas don't need oxygen to deliver babies. They don't. But if mama runs into any trouble, you throw oxygen on her and you put blankets on her and protect her warmth and you get the hell out of there. Because you don't got a lot of time when there's a problem in delivery. You've got minutes before this baby is no longer receiving oxygen to its brain. It tells you what to do if the sac doesn't rupture. You can rupture it. You can poke it with a clamp, or you can tear it a little bit with your fingers. Don't go getting out your shears and stuff, folks. You're right by the baby's head. Mess around and whop off a piece of vagina and they're going to be angry. Definitely don't want to cut the baby's head. Umbilical cord around the neck. First, try to slide it off. Try to slide it off around the baby's neck. If that doesn't work, cut that cord. That's correct. We're going to try to work it over the baby's head. It almost always works. It depends how tight that cord is and how progressed in labor you are. If you can't work it around the baby's head, you cut that cord. You must ensure that the baby's neck, face, and head is clear of that cord, especially the neck. Everyone thinks it's to prevent the baby from smothering. That's so dumb. It's to prevent the cessation of blood flow to the carotid arteries that are feeding the brain. If the cord is tight enough to squeeze off the right and left carotid arteries, then the baby will not oxygenate their brain. That's how you get cerebral palsy. That's how you get lethal anoxic injuries. That's how you get a kid who'll never talk, never walk, never do anything. That's how you get a kid who dies in resuscitation. APGAR. You got to learn APGAR. It means appearance, pulse, grimace, activity, and respirations. We're going to look at it. If mom delivers baby and the baby has more than 500 cc's, not the baby, and mama has more than 500 cc's of bleeding, all throughout this class we've said that 500 cc's is the cutoff. If you bleed more than 500 cc's, this is dangerous and you're going to die. Then we need to start trying to help mama not bleed. The first way to do that is take the baby and put it on mama's chest and see if the baby will suckle. When babies suckle, it releases oxytocin from the brain. Oxytocin is known to cause vasoconstriction. If you're bleeding, vasoconstriction is quite lovely. It helps the bleeding stop. If you can't do that, or even if you can, you will then start massaging the fundus. The fundus is the uppermost portion of the uterine wall, and it's the hard part, the thicker part of the muscle that you feel. The baby's out now. Baby's out. Placenta's probably out. And mama just won't stop bleeding. So we're going to massage the fundus. Massage the fundus in a kneading motion, they say. And that also secretes oxytocin, causing vasoconstriction, which helps with bleeding. Once that baby comes out, the most important things you see here on this slide are dry and warm, dry and warm, dry and warm. You are going to physically take blankets and you're going to dry the baby, dry the baby, dry the baby, dry the baby. Rub its chest, rub its back, rub its chest, rub its back. And what's it going to do? Start screaming. And that's what we want. You can tap it on its feet, just like we learned in the American Heart Association BLS provider course. Tap, tap, tap on those feet. The first minute of life is the golden minute, and that is when I want to see this baby get pissed off. And if it doesn't, then we're moving towards a scenario of the 10% that require resuscitation. We're going to dry, warm, and stimulate. Dry, warm, and stimulate in hopes of making that baby breathe. How do we stimulate? Rub its chest, rub its back, tap its feet. Dry it off with blankets. Gets the baby going. Babies should be born breathing more than 20 times a minute. Maybe even 30 times a minute. Their heartbeat should be greater than 100 beats per minute. They come out looking blue, but quickly they should pink up. The core of the patient must pink up immediately. The periphery of the patient, the arm and legs of this newborn beautiful baby, they can stay blue a little longer. That's called acrocyanosis. And that's acceptable in the first few minutes of life. But I should start seeing that improve. The core of the baby should come to pink quite quickly. The arms and limbs should follow shortly thereafter. When babies are born, make sure mama's okay, and then make sure baby's okay. How do we do that? Baby should get an APGAR score at the first minute of life and at the 10th minute of life. The first APGAR score should at least be better than 7, and the last APGAR score we want to be around 10. You can get 2 points per piece of APGAR. There's 5 pieces, and that brings you to an APGAR score of 10. So we like to say 10 by 10. 10 APGAR score by the 10th minute of life. You need to know that babies don't perfuse very well in the first few minutes of life, and it takes up to about the 10th minute mark for their oxygen level to be reliable by SpO2 and for their bodies to be fully pink. 10 by 10 and progressing. So even if I come out and I'm not a very high APGAR score, I should quickly become a high APGAR score. So again, APGAR score at the first minute of life and at the 10th minute of life. I'm going to come back to this. Let me see if I can get... Here's APGAR. Appearance. Pulse. Grimace is how angry are they? Are they crying? Is their face all mad and scrunched up and angry? Or are they just kind of laying there? Activity and tone is whether or not the baby resists you. If they resist you straightening them out, that's good. Babies like to be in the fetal position because they've been in the fetal position their whole existence. And it seems to be going damn well, if you ask them. So they don't want you to stretch them all the way out and put all their little ditties out in the middle of the open where they can't protect them. So it's only natural that kids want to bring themselves into fetal position. If this kid's just laying there limp, they get a 0, and that's bad. If they are a little weak and they don't really give you much, that's a 1. And then if they try to fight the daylights out of you, that's what we're hoping for, and they get a 2. Okay? You can see that appearance, we allow acrocyanosis in the beginning, and then they should become pink. 0 for pulse if they have none. 1 if it's less than 100. We're going to do compressions on that, by the way. You're going to learn in just a minute. If it's less than 60. So that heartbeat should be greater than 100. And if it is, that's a 2. We already talked about grimace. Are they looking angry? Or are they crying? So if they've got a weak cry and you've got to kind of tap them and make them cry, that's a 1. If they're screaming and hollering, that's a 2. And if you tap them and they're not doing nothing, you're drying, you're stimulating, you're tapping those feet, and they give you nothing, that's a 0. Guys, you got to look at APGAR. It's not hard. It's pretty common sense even. You need 1 in the first minute of life, and you need 1 in the 10th minute of life. We compare the first one to the 10th minute of life, APGAR, to make sure the baby has progressed. This is a judgment of how likely the patient is to need resuscitation. If at any point the baby is not breathing, breathe for that baby. If at any point the heartbeat is less than 60, you are going to start compressions. The compressions to breath ratio on a neonate is 3 to 1. 3 to 1. Push, 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 breathe. Push, 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 breathe. Push, 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 breathe. Push, 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 breathe. We say 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. That's how we do neonatal resuscitation. Obviously, that is going very fast. So you need how many people? At least 2. At least 2 people are necessary to provide effective resuscitation of a neonate. Guys, neonates don't typically go into arrhythmias that are shockable. Typically, their problem is oxygenation. You should focus on breathing for these babies. If the heart rate's less than 100, start oxygen, start PPV, positive pressure ventilation. If the pulse gets below 60, start compressions at a ratio of 3 to 1. I bring you back to the resuscitation slide. Here's an example. Our thumb encircling technique. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. It is very easy to pop the lung of a newborn. So only give enough air to cause chest rise. You must ensure an open airway and a good seal on your mask. They make neonatal eye gels. They make neonatal king tubes. You should use them if you possibly can. It's going to take some time, and it's going to take extra hands to get all that stuff out and ready for you. But it will make your positive pressure ventilations more effective if you have a rescue airway. Meconium staining we already talked about. Here it is. All right, we already talked about APGAR. I already told you about breach. You can read about it. We already talked about cord, nuchal, and otherwise. Make sure you know how many babies are in there. That's embarrassing. I'll let you look at premature. You are going to see some test questions about how long should the baby be in the oven. Anything less than 32 weeks is too early. Anything more than 42 weeks is too long. There's bad sides both of that coin. Anything before 28 weeks is typically not viable, folks. The lungs aren't developed enough at the 28 weeks. If a young mama drops a baby in a toilet that ain't breathing at the 20-week mark, please don't try to resuscitate it. You cannot save that baby. Okay? We are seeing babies get saved at younger and younger and younger week marks because of modern intensive neonatal care. And we're very proud of that. Kids that would not have ever been alive are alive today due to the advancements of modern intensive neonatal care. But those kids came out trying to breathe. Those kids came out trying to live. Typical guidelines will suggest that if a kid is fully delivered, not breathing with no pulse, before the 28-week mark, we would not typically provide resuscitation to that. It's futile. It is more likely that this kid would be harmed than helped by resuscitation in that time frame. When you go work somewhere, take a look at that number. It may be different at your agency. Your doctor might have been more conservative or less conservative with that number. Pay attention to that number at your agency when it's likely that you won't be performing resuscitation on a baby. Again, we're talking about a baby that is not breathing and has no pulse. If a 24-weeker drops into the toilet because mama thought she had to poo-poo and instead she had the baby and it's trying to breathe, then help that baby because that baby is trying to live and we might be able to save that baby. So we're only talking about not resuscitating kids who are futile. They are not breathing. They don't have a pulse and they are well before the 28-week mark. All right. I already gave you the answer. The first stage of labor ends when the baby presents. That's the end of the first stage of labor. First stage of labor began when there was a contraction, and it ends when the baby's head starts to present. We call that crowning, by the way. When the head breaks through visibly through the vaginal wall, and we can see it coming out, that's called crowning, and it is the end of stage 1. What's the answer to this question? That is correct. High blood pressure is preeclampsia. 8 months pregnant, to prevent supine hypotensive syndrome, position the patient how? The best answer's on their left side. Semi-Fowler's isn't a horrible decision. It's still better than being on their back. However, if they're really, really pregnant, then maybe even Semi-Fowler's isn't enough. That left side's always going to be your best bet. Immediately after delivery of the infant's head, you should what? Now, we know that all babies don't need suction, but in this case, they give you A, which does one before the other, and B, which does one before the other. So I guarantee you were probably thinking A or B. You need to read on. Assess the baby's breathing effort and skin color. Well, that's a good answer. Check the position of the umbilical cord. That's a really good answer. The first thing I want to know when that head comes out is the cord nuchal? It's not likely that a brand new presenting baby is breathing in the birth canal. That is not likely. So then it probably does not need suctioning. I would first check for that freaking cord. That's what I would do. Upon delivery of the baby's head, you know that the umbilical cord's wrapped around its neck. What do? Try to slide it over the baby's head. If that doesn't work, clampy, clampy, cutty, cutty. Now, you do want to clamp the cord before you cut it, unless you just simply, it's so emergent, it's so bad that you can't. Say mama is continuing to push and you can't get her to stop. Well, then you might just have to cut that cord with your shears. But you do typically want to clamp the cord. Why? It's bleeding. It's got blood running through it, arterial blood running through it. Yes, Miss Cynthia. Okay, moving on. The need for and extent of resuscitation is based on what? How do I know to resuscitate a newborn? Delta, all the way. It's about the APGAR. APGAR tells us that the patient's breathing good, heart rate's good, and color and behavior is good. And so D is the best answer here. 1 minute APGAR of a newborn reveals the baby has a heart rate of 90. Ooh, it's supposed to be greater than 100, but that's better than 60, so I'm going to give it a 1. Pink body, but blue hands. I'm going to give that a 1. It's acceptable at the first APGAR, but by the 10th minute mark, it should all be a 2. Rapid respirations. Well, that's a 2, so now we're at a 4. The baby cries when the soles of its feet are flicked, but you had to stimulate it. I don't like that, so that's a 1. I'm going to give it a 5 now. And resists attempts to straighten its legs. That's a 2, so 6, 7, and 7's not on here, so I'm going to go with B or C. Which one y'all want to go with? I'm going to say B. I'm going to say this baby's got an APGAR of B. Well, we must have underestimated one of those bad boys. Let's see what they came up with. They said that a heart rate of 100 beats is assigned a 1, below 100, so that was right. A pink with blue on the hands and feet, it's a 1. We got that right. Rapid respirations was a 2. We got that right, so that was a 4. Strong cry and a stimulus is a 2. Ooh, that's not true. They kind of gigged us a little bit on that one now, because it's supposed to be a strong cry without stimulus. Oh, well, it does say a weak cry with stimulus versus a strong cry. So I see what they did there. I agree. I should have given more love to that, even though it required a little stimulus. So if you guys went with C, then you're better than I am at APGAR scoring. By the 10th minute mark, though, that bad boy better be 10. Or close to 10 at least. You will have to do a couple APGAR scores, so you got to pay a little bit of attention to that. The most effective way to prevent cardiopulmonary arrest in a newborn is what? What did I tell you was their problem? Yeah, make sure they're breathing, make sure they're oxygenating, and they won't go into arrest. They've got good hearts and good lungs, typically speaking, statistically speaking. While assisting a woman in labor, you visualize a vaginal area, you see an arm protruding. She tells you that she feels the urge to push. What do you tell her? Don't freaking push. There's a book answer here. What do you think that answer is? It's so dumb. Yeah, it's silly, but A's the right answer. You need to get the hell out of there and try to keep mama from pushing. Now, you can't force mom not to push. It's an urge. It's like telling someone not to poop. You just can't do it. Like, once you get the urge, you got to kind of do it. But you can try to breathe. Try not to push. And let's go. We got an emergency. Tell mama what the emergency is. Mama, there's an arm coming out. Don't push this baby yet. If you can help it. And then get the hell out of there. And they say cover the arm with a sterile towel. That's so damn dumb. The arm is fine. Get out. Newborn considered to be term is born after the blank weeks and before blank weeks. Anybody? Leslie's going with B, and I support you, Leslie. The truest answer is we want that baby before 42 weeks, and we want it to be 40 weeks. So 37 to 42 is where we're going. 40 weeks is the best answer. Okie doke. We've earned a break after all that. This is a good chapter, guys. It's a big chapter. One of my favorite chapters. You got to really look at it. If this is brand new information to you, you've never one time taken a second thought at a pregnancy, you got to really read on this. We'll come back at 7:45. All right, we have a question upon the board. Don't get quick, people. Asking before I forget, will the final exam be taken in class or proctored remotely? And will it be cumulative of all the previous quizzes? I think a better way to say it would be all the previous exams. But yes, the exams are made up by the quizzes. So yes, it will be proctored in class, the last week of class, except upon extenuating circumstances that are approved on an individual basis. I think that was the legal jargon put in the handbook. Raise your hands in the air like you just don't care. 14. We only have 11. There's 12. One more. Who's at the bottom? Vishnu. Vishnu, you're never the last to the party. Where the hell is Vishnu? Anyone? There we go. That's better. Oh, Vishnu. Ariane's typing. I'll just answer you when you put your question up. Let's go to...
I'll just unmute so it's easier. Is it like the next week? Is the last week? Oh wait, no. Not next week, but the week after that. Is that the last day of lab?
Yes. And so, strategically, you would take both. You would have to take, what I've done in the past typically, is Module 7 in the beginning of lab, and the final exam at the end of lab. Does that make sense?
Okay, I think I might have an extenuating circumstance.
Okay,
So I
just
might have to
discuss it
talk
with
to you
me
after.
in lab.
Okay, yes sir.
Okie dokie, and we'll deal with that if conditions apply. If it's not extenuating, then that won't apply. But if it is, then we will review it. Yes, Charlotte, for the love of God.
I'm so sorry. I just was confirming. So you said that we would be taking the module exam at the beginning and then the final exam towards the end. Is that correct?
That's right.
Okay, thank you. Sorry.
You're fine. So this week, the week of the 28th, we take trauma module, Wednesday, Thursday. December 5th, we take, the week of December 5th, we lecture for the last time, for the last module, December the 5th. You'll take special pop module, December 7th or 8th. You'll come back for the 12th, and you will have the 14th and the 15th to take operations in the beginning of lab and the final exam at the end of lab, so that by the time we finish class on 10 o'clock, December 15th, I will know that you have or have not passed the class. Does that make sense?
Wait, I thought class ended on like the 11th. So it goes to the 15th?
Yeah, I don't know why she built the 11th. I'm looking at that now and I see it too. But that will not work. So we need to double check what I'm looking at right now and see if she did something smart and not being dumb. Okay, so that would mean on 7 and 8 you take special pop, and on 14, 15 you take operations, and yeah. So we have a choice. We could there's no way. You would put too much on you guys. You'll have to have the week of the 12th. You'll have to. And so I'll run a poll. I'll figure out lab how costly this mistake is, that it was oversighted, and see what we need to do about it. if we end up having to turn the final exam into a virtual, then that's what we'll do. But we can't. I don't want to put too much on you guys at one time and then stress the whole thing out, and then you do poorly on an exam you would have otherwise done fine on. Because this week we're covering Special Pop. That gives you 7 days to learn Special Pop and test it next week. Next week you spend learning operations, which you would then take on the week of the 12th. If I don't do it that way, then that means you have to take the exam virtually by Sunday the 11th. We'll run a poll in lab and see what works best from you guys. I don't suggest we close the class on December the 11th unless, I'm not going to tell you what I'm about to say because then you'll just lie to me. So I'm not going to let you lie to me. I'll run a poll and I'll see what the conditions are. And we'll go from there. Okay? Either way, we'll get it done, but I'm not going to rush you guys and then have you do poorly on exams. I'm not going to do that. So I'll figure that out. Let's not worry about it right now. Okay? We'll figure it out this week in lab. If someone will remind me both days to address in lab how we want to close out the course. And I don't really care either way because I didn't oversight it. So they shouldn't have closed the course a week before. That last week needs to be an exam week. And they basically didn't make that week an open week. They closed it. So, all right, moving on. 35. I need to screen share for 35 because it's so freaking big. Disgustingly so. Pediatric emergencies is 260 slides. We should progress through them quite quickly, overviewing principles. Now, I cannot see your messages. Hold on. I could make it so that I could. I've done that before. I don't want to do that. Public chat. Okay. Now I can see your public chat. No. Stop doing that. Oh, crap. All right. If we need anything else, just speak up. I have it now where I can see. You should probably be able to see my screen, and you know that I do. So here you go. Pediatrics. In pediatrics and in geriatrics, there's going to be this huge overriding concept of they are very susceptible to abuse and neglect. The difference between abuse and neglect is abuse is physically, emotionally, psychologically, intentionally harming a kid. Trying to actually harm them physically, mentally, spiritually. Neglect is, I should have never been a parent, and I have no business being a parent, and I'm just letting this kid run in the road, be butt naked. It's cold outside and snowing, but I don't care what they're wearing. They're, wearing diapers, and I got them out there with no shoes, no nothing, playing in the snow. Well, that might be neglect. Not having any food in the house, that might be neglect. Not having lights and electricity and water, that might be neglect. So that's the difference between abuse and neglect, both of which we need to watch out for. When we're in the home of a kid, have your spectacles on. Look around you. Does this place look safe? Are people paying attention to kids, or are they being ignored? Is there food in the house? Does the pantry look empty? Is the AC broken and it's 20 degrees outside and it's 20 degrees in here? Is it 100 degrees outside and 100 degrees in the house? You got to pay attention to these things because we are required, if we see a problem, to say there's a problem. So that's an overriding concept of both this chapter and the geriatric chapter. So pay attention to that. We've said it before, we'll say again, pediatric emergencies are almost always airway, airway, airway. Airway from disease process like asthma, infection, the flu, COVID, pertussis, which is whooping cough. They catch everything because they don't have as developed of an immune system as you and I. And so they're always experiencing respiratory emergencies. You should always have this overwhelming goal of making sure that anything below the age of 12 is breathing effectively and oxygenating effectively, because that is what will kill them. So we'll talk a lot about that. Kids do not show shock the way adults show shock. Adults show shock in its defined phases typically. There's a period of compensation, notably, everything's high. There's a period of decompensation where things are getting low. And then there's a period of irreversible shock where it is very clear the patient is dead or is going to die very quickly and very shortly. Children, because they are typically more organically healthy, meaning they have not had long periods of time of doing the wrong things to their organs, like smoking, drinking alcohol, eating fried chicken every 5 minutes, high blood pressure, cardiac disease, kidney disease, all these things that we do to ourselves. Well, they haven't had the time to develop those bad things. And so they have good hearts, good lungs, good brains, good kidneys, who are very capable of mounting a significant compensated shock. For this purpose, we call these kids cliff divers, because children tend to compensate until they literally go into arrest. So we call them cliff divers. You don't see high vitals, high vitals, high vitals, high vitals, low vitals, low vitals, low vitals, low vitals. Okay, is he breathing? Does he have a heart rate? You don't see that in kids. You just see tachycardia, tachypnea, tachycardia, tachypnea, tachycardia, tachypnea, dead. They don't go into this obvious decompensation. So be careful with that. Here's why. Where are they in the shock process? How long have they been in shock? It's hard to know because they mount such a significant compensation. So then you can't get comfortable with the idea of, okay, well, this is in the early stages. We've got time. You don't know that with kids. So treat all shock in kids as though it might soon be a cardiac arrest, especially if that shock is airway driven. Kids do tend to have seizures. We'll talk about that. We'll talk about specifically febrile seizures. The book is going to be very clear that febrile seizures are seizures in young kids less than the age of 6. That's a test question. Less than the age of 6, typically. And febrile seizures occur when a child's temperature rapidly changes to a high temperature. So say they catch some flu or some other type of illness and they spike this good fever. The quickness in that change might result in a febrile seizure. Common, less than the age of 6. We'll talk a little bit about SIDS. I'm going to let y'all read that. Upper airway obstruction versus lower airway obstruction. I would hear stridor in the upper, wheezing in the lower. That's a test question you've had before. They're going to talk a lot about the differences in the airway of the child versus the airway of the adult. The big remembering takeaways are the child's airway has a much bigger tongue. The child's airway tends to funnel into narrowing. So in the adult, the most narrow part of the airway tends to be in a different place than the most narrow part of the pediatric airway. That is a test question. You need to pay attention to what the answer to that question is, and we're going to see it in just a few seconds. So the tongue is bigger, the head is bigger, and the airway's internal anatomy tends to funnel into a narrow placement different from that of the adult. We're going to look at that. Remember to bring calm to chaos. If parents are helpful and calm, we need to use them. Parents are the most informed people about the child having an emergency in front of your face. it makes only logical sense to engage the parents or caregivers that know that child and know the condition in front of you and get the information you need from them. The idea of sending parents to the front of the truck and trying to care for a baby in the back by yourself because you're so freaking intelligent and you've been trained to such a high level is bullshit. If you ever see paramedics and EMTs sending parents out of the truck and to the front, know in your soul that those people are stupid and you shouldn't be doing anything that they do. Don't take any lessons from those people. In fact, folks, unless a parent is preventing you from effectively caring for a patient, you don't have the legal authority to tell a parent to get out of the truck while you take care of the patient and get to the front of the truck. The parents have a right to be involved in the care of their child unless they are presenting in such a way that impedes or prevents your appropriate treatment of that child. There's a known unapproved rule that parents don't ride in the back of the ambulance. That is bullshit. It is not real. It's not allowed. And it even can become, depending on the statute you apply, illegal. Children should be in the presence of their parents unless it's not appropriate to do so. You're going to see the growth and development material go through again in here. So make sure you look back through that. You cannot possibly understand what the appropriate mental status of a child should be if you don't know where they are at normal. Where should the child be? What is the expected mentation? That is going to be information you achieve from your familiarity with growth and development. So make sure you, again, take the time to pay attention to that. We do consider the pediatric chapter everything up to 18, but guys, I reiterate to you again. In the terms of emergencies, the most life-threatening emergencies, we're looking to the age of 12. We're looking to the development of puberty. Once puberty begins, this child will typically be treated as an adult. If you look at your trauma criterion, the adult trauma centers treat anything over the age of 15 typically. Some may say 16. And then the pediatric hospitals will indeed take patients up to the age of 18. So it's not to say that the terms don't get granular or very specific, but it is to say that by the age of 12, a person has reached developmental characteristics of that you'd see in the adult, especially in growth of height, development, and sex. If the ideal body weight of this person is appropriate for age and sex, meaning male versus female, and they're the age of 12, they have signs of puberty like pubic hair or development of breast, that person's an adult in the terms of the medical emergency world. And the board-certified emergency physicians probably that are for peds don't want me to say that, but that's how we do it in our world. Pediatric patients are not little adults. We can't treat them like little adults. Their anatomy is different and their bodies behave different, and so then we must treat them differently. That applies most to the younger children. Example being, if you had a low blood sugar right now, I'd start an IV on you and I'd give you dextrose wide open. I would just push it and voila, you'd wake up and everyone would say, oh, God's been here. It's been fixed. You went from looking dead to you're suddenly alive. You can't push volume on young children like that, especially the neonate. So you got to be careful about the differences in children versus the adult. They're not little adults. If you hear a paramedic say that, that's not a very smart paramedic. Hold on 2 seconds. I got to plug this thing in before it dies. I really thought I was going to get away with not plugging this thing in, but I knew better. Or should have known better, rather. All right. Save the day. We're good. So that's my talk about people calling peds little adults. They're not. When you go work at your services, guys, you're going to have bags that are specific to pediatric patients. And so I'm going to give you some things to go look at. Okay? I want you to go look at Broslow tape and Broslow bag. These are doctors who went out of their way. I want you to go look at Hantevi. These are doctors that went out of their way, board-certified pediatric emergency physicians, that went out of their way to say EMS can take better care of kids. Emergency rooms can take better care of kids. And they can do so using my system. And so they came up with these systems. I would argue that Dr. Peter Antevi, one of the most brilliant EMS minds we have ever known in our time, the things I would say about this man towards his passion and knowledge for EMS and what he thinks we are capable of is unable to be told. He is an incredible, incredible man, and he created a system called Hentevi. And I'm not saying that Broslow isn't good, because it is. We used it for a very long time. Most places still use it. It's an incredible system also. But there were problems with it, and it's all weight-based. And I won't say all. A lot of that is weight-based. Hantevi, Peter Antevi, Dr. Antevi, came out with a system that uses height and sex based on ideal body weight to treat children. And he did it off of a system called Hantevi, which basically, if you put your hand up, your thumb is 1-year-old, your next finger's 3, then 5, then 7, then 9. And he applied a kg thinking to that. A 1-year-old expected by height and development is going to be 10 kgs. And then the next finger is 15, and the next finger is 20, then 25, then 30. If you're the guy or the girl pulling the trigger on medications for a kid, that just made it immediate. Before Peter Antevi had thought of that really simple trick that I have no idea why we weren't doing, it was much more difficult. You were having to read tape, and you were having to memorize these numbers. And there's still memorization, there always will be, but he took the world of PEDS and said, stop ignoring this population. They can be treated effectively by EMS. Here's how. Go look at Broslow. Go look at Hantevi, both of which are great systems. I, of course, think Dr. Peter Antevi is the EMS Jesus. So take a look at that stuff. It's real important. Here's the slides that matter. You're going to see a lot about this. The pediatric airway is smaller and shorter. Simple. The lungs are smaller, so that means your overventilation is more costly. Keep that in mind. The glottic opening sits higher. It comes up more superior and anterior, meaning it's more difficult to coax the air from your bag valve mask into the lungs of a child than it was the lungs of the adult. You're going to have to even be more attentive to the seal on your mask and the opening of your airway if you're going to ventilate this kid correctly. Okay? The tongue is much more larger. The neck is longer with a bigger head. So what does that mean to you? It means that they naturally want to occlude their airway even more so than the adult. How do we overcome it? Simply put a towel roll, a blanket, some sheets right underneath their shoulders, and even, if necessary, underneath their head to bring the head up to a matching natural position of the chest. You're going to see us do this a lot. Placing towel rolls and blankets under the shoulders and head of a pediatric patient will make you effectively able to manage airway. The book may show some pictures of that. It's going to help you overcome the anatomical differences and challenges in the pediatric airway. They are more difficult to ventilate. Put some towel rolls underneath the shoulder line, maybe based on the position of that particular kid's head, because if they're younger versus if they're older, you might need some towel rolls underneath the actual head. You want to line the head up with the chest, something we call ear to sternal notch. The edge of the ear to sternal notch. You want to raise the head upwards and make it line up, not the neck, the head, and make it line up with the chest. Not always easy. It may require some towel rolls under the shoulders. It may require towel rolls and blankets underneath the head, depending on whichever patient you have in front of you. Here's some test questions for you. Narrowing and funnel shaping in the upper airway. A U-shaped epiglottis. Proportionately larger tongue. Bigger head. This is the stuff we've been saying. It's reiterated here, and it is a difference from that of the adult airway. Make sure you know that difference. Respiratory rates are much higher in children, so then hypoxia develops more quickly in children. If their lungs are smaller, their airways are longer and more difficult, more anterior airways, meaning that the glottic opening sits more anterior than that of the adult, then they develop hypoxia quicker. So then we have to be more aggressive in the airway management of pediatric patients. Heart rates are substantially much higher. Here's a chart that goes along with that truth. Remember that big old head is much larger, so their closing of the airway is very natural. If a child is not awake and is unconscious, not able to have productive brain function, they easily close their airway due to having a much larger occiput due to the anatomical changes we've mentioned about their airway. Look at this bad boy. Spinal cord injuries are less common in children. Some of the dumbest crap I've ever seen is when a child is beating the daylights out of the fire and EMS providers trying to put them in spine motion restriction. I say to you, what spine cord injury have you potentially prevented or treated if the kid is killing everybody on scene to get out of spine equipment? The whole point of spine motion restriction was that you didn't move them. If they're fighting you, just leave the equipment in the frickin' ambulance where it belongs, because none of that crap shows any success in the data, and talk to the patient. Hey, I need you to lie real still. We're going to put towel rolls and blankets around your body just to make you more comfortable, okay? You can build a little cocoon around kids just as effective, if not more, than spine motion restriction equipment. Don't beat a kid into submission with spine motion restriction because it won't work. By the way, make sure you know that SMR equals spine motion restriction, which is basically putting a patient on a long spine board and securing them in a C-collar with head blocks and 3 straps, as we have learned in class. I'll let you read that stuff. That's just development stuff. Remember that kids get colder faster. They lose volume faster. They become hypoxic faster. So we say that kids are stable emergencies. We don't mean that the emergencies they experience are stable. Stable is an acronym that you better remember from this moment on. What goes wrong with children? It's the same applicable things that go wrong with the geriatric patients. Sugar, temp, airway, blood pressure, labs. That's not really you, but their labs go a whack pretty easily. And their environment. Their environment is a big deal for them. If the environment's cold, that kid's going to get cold. If the environment's too hot, that kid's going to quickly get too hot. What's wrong with kids? Stable. If you have a kid in front of you and you're like, I just don't know what's wrong with this kid, the acronym you should be using to alleviate the field impressions that are not applicable is stable. What is their sugar? Keep them warm. What is their temperature? You have to keep kids warm. In the neonatal world, you almost can't keep them warm. It's just that difficult. You are losing the most heat from this kid from their scalp, their neck, their axilla and their groin, their chest and their belly. Keep those things covered. If you ever see us taking care of kids, we literally make a big cocoon of blankets. The only thing you can see of them is their little nose and mouth. We cover everything else because kids get cold, and when they get cold, their emergencies persist faster, they get sicker faster, and they die more often when they're cold. Stable, stable, stable. What is the sugar? What is the temp? Keep them warm. Treat airway, treat airway, treat airway. Do I need to give albuterol? Do I need to be giving oxygen? Am I being aggressive enough? Blood pressure. How do you detect blood pressure best on a kid? Cap refill is best on children. Can someone remind me what capillary refill should be less than? 2 seconds. Dylan has just exhibited the kindergarten rule. Some of you probably said to yourself, I have no idea what the hell he's talking about. The kindergarten rule says that if one of your peers knows about it, then you should have known about it. Capillary refill is simple. You press your finger into their nail bed. You press it into the palm of their hand. You can even press it into their forehead, and all the blood squirts away from your finger pressure, and that area becomes white. You let it go, and the blood instantly fills back in. That would be normal. If the capillary refill in the pediatric population is greater than 2 seconds, that's equivalent to a bad blood pressure. I'm now worried about their blood volume. I'm now worried about their hydration volume. Is this kid dehydrated? Is this a kid who's been having diarrhea and vomiting for greater than 24 hours? If that's true, this kid is hypovolemic. Hypovolemia is one of the normal emergencies we see with kids. Things that shouldn't have happened to them, things that people should have caught, things that we didn't catch. Hypovolemia in kids, big deal. The blood pressure in stable equals check their capillary refill and be super high index of suspicion that this kid is dehydrated. As you and I well know, children will vomit and experience diarrhea at the drop of a hat. In fact, diarrhea is still a top 3 leading cause of pediatric death in the world. In the entire world. Why is that? Because it hits so fast, it is difficult to correct, it is difficult to get children who feel unwell to take in the right amount of fluids, to take the right type of fluids, and so quickly they can become hypovolemic and no longer be able to perfuse. You must be on top of the whole capillary refill and hypovolemia talk with kids. Stable, stable, stable. In the pediatric world, this is a test question. We replace the general impression with the pediatric assessment triangle. The pediatric assessment triangle does not require you to put your hands on the patient, just like the general impression didn't require you to put your hands on the patient. You're looking at their appearance and everything about that. What color are they? How do they appear to you in activity, in grimace, in tone? Are they moving? Are they crying? Are they acting like a kid is supposed to act? Angry kids make us happy because we know that they're perfusing. Appearance is grimace, tone, movement, behavior, activity. What are they doing as I walk across the room? Work of breathing. We want to look a child toe to head. I'm going to repeat that. We want to look up children. Children don't do chest rise very well. They do belly rise better. They have these big Buddha bellies, right? And so you'll find a lot of literature that discusses assessing children toe to head, toe to head, toe to head. We assess adults head to toe, head to toe, head to toe. The reason behind the toe to head thing for children is because they Buddha belly breathe, and so it's easier to really get a good feel for their work of breathing, looking toe to head. So as you approach that kid, look toe to head and ask yourself, are they working hard to breathe? Circulation to the skin is about color. Children are the best hemodynamic shunters among us. They have really healthy vasculature, and they have really healthy hearts, and hopefully they have a good volume so that they can yank the blood away from the areas that don't need it during a time of compensation and surround those central core organs with that blood in a time of need. When they do that, clearly they have a color change. Acrocyanosis, mottling, where they kind of look like they're all kinds of colors. Ashen, gray, cyanosis. Those are all potential color findings in a kid who is trying to compensate and is showing signs of shock. Is the skin color pink and vibrant as expected? If they require a deeper dive, then get on in there. But the pediatric assessment triangle is your general impression when it comes to kids looking toe to head. We are going to assess children using the ABCDE mechanism. Okay? A, airway. B, breathing. C, circulate. Oh, I put a V in there. C, circulation. D stands for disability. Why isn't this kid looking at me? Why isn't this kid crying? Why isn't this kid moving and showing tone and vibrant and angry? Why is this kid sleepy? Why is this kid inconsolable, unconsolable? They will not stop crying regardless of parent intervention. Disability talks about mentation. What is the disability of that kid? Should they be conscious and they're unconscious? Are they obtunded, where they're super out of it? You can't really get much out of them on the AFU scale. They're definitely in the pain/U area. So that's what disability really talks about. And then E goes right back into environmental, just like we did with stable. And it also discusses exposure. You cannot take care of kids if you can't see their bodies. How the hell are you going to assess a kid you cannot see? Get the clothes off. I don't know why in 2022 we're still screaming to advanced nurses, advanced paramedics, long-time practicing EMTs, long-time practicing physicians to get the clothes off of people who present sick. You can't possibly do the things this chapter is teaching you to do if you can't see your patient. Get the clothes off. What is the temperature of this room? What is the temperature of my patient? I know I have to keep this kid warm. That's what you're looking at with E. So we don't just look at kids with A, B, C. We also put in that D and E assessment to tell us more about them. If a kid's had vomiting and diarrhea for 2 days, and when you get there, they're super sleepy, very lethargic, don't really want to give you much attention. They're 1 year old and 2 years old, and they're not crying. They're not interacting with their parents. They're not moving around all over the place. They just kind of lay in bed. That is so freaking abnormal for that age population, yet we're missing it. That disability should be glaring at you, yet providers are missing it. Then you couple it with a capillary refill that's greater than 4 seconds. Then you couple it with a heart rate that's 180 beats a minute, breathing rate that's 30 times a minute. It's very clear that this kid is tachypnic, tachycardic. The mental status is very disabled. This kid's hypovolemic. They've been vomiting and diarrhea for multiple days. They're very disabled in mentation. That's a clear case of dehydration that has now resulted in shock. If uncorrected, this kid's going to die. The Tickles mnemonic helps you keep the mental status of children in mind. Tone and movement are super important. Kids should be vibrant. Do they interact with people? Are they consolable? Look and gaze. Are they just kind of looking around the room and not being able to focus on you? Children should look at you. They're curious. Okay? And are they crying? Are they speaking? We want kids to be angry. The younger kids. Already talked about that. Nasal flaring is a big deal in kids. The younger kids, the cartilaginous tissue around their nose is not as developed as you and I. And so when they run into respiratory distress, the sides, the inferior lateral sides of the nose will kind of flare. And that's a telltale sign that children are in distress with their breathing. Another thing you'll see us talk about a lot is grunting. And I don't see grunting on this slide, but it should have been. When kids get into trouble breathing, they'll actually start making a little bit of with their breathing. Now remember, their breathing is really fast, and they take these little short breaths. And so eventually they get tired. And so they're trying to couple their breathing with this bearing down, this grunting sound, and that grunting muscular motion to get more out of each breath. And we should pick up on that grunting. We should pick up on the nasal flaring. Remember, large majority of children experiencing emergencies is secondary to a compromise in airway. These kids don't breathe well out of their mouth until the 1, 2, 3, 4-year-old range. They're nasal obligatory breathers. If you start clogging up their nose with a bunch of mucus, if they get the sniffles and that turns into dry, crusty blockage, that can actually be enough to progress a kid to hypoxic arrest. You've got to clear the nasal passages of a kid. That's their dominant method of inhalation and exhalation. They're not good mouth breathers, and as they are young children, they don't breathe out of their mouth at all. And so we have done a lot of work in studies to show that a ton of respiratory compromise with children that required advanced intervention could have been prevented by aggressive nasal passage management. That's why when you go look into the CVS, the Walgreens, the Walmart, you'll see a ton of stuff in the children aisle section for nasal solvents, like normal saline passage help. You'll see those little bulb syringes. We're doing a lot to try to humidify the nasal passages of kids and get that dry, crusty crap out of there, because that's their dominant mechanism of ventilation. That's how they run afoul. Everyone thinks of kids as picking something up and putting things in their mouth. And of course, those kids exist. Foreign body airway kids exist. A lot of those kids, though, are having airway compromise simply because we're not paying attention to the dominant method in which they ventilate. I already talked a lot about the differences in the assessment versus the pediatric assessment triangle versus general impression, XABCs or ABCDE versus just looking at ABCs. Okay, we looked at X a little bit in the trauma chapter, and kids are for sure susceptible to trauma. They don't do well with trauma, but that's obvious, right? And X is obvious on those kids. Again, expose. Look at the kid, front and back. You cannot treat what you cannot see, people. And then you've got that disability and exposure that we talked about. This is great stuff, guys. One of the best chapters in the book. And a big chapter, arguably. You do need to know that we can't secure children in ambulances just any old kind of way we want. There are special devices for that, and they must be used. You cannot just willy-nilly put kids in cars, put kids in ambulances. Everyone says, well, listen, ambulances is an emergency, so we're covered. You're not covered. If you get into an accident and this kid is killed because of the accident, you are not covered to not have the kid secure. So we have lots of devices for that, like this. PEDS, for example. This is the old PEDS here, a really good device. And here's a good picture of old PEDS doing its job. Okay, and the PEDS goes up to like 40 pounds. And then we also have this ugly little thing, the Neomate. here's the Neomate with its little head cartridge. And this thing is brilliant. We have one of these on the aircraft. Where the fuck did it go? Here it is. We have one of these on the aircraft. Super good little device. And they strap to your stretcher, people. They strap to your stretcher. Now, there's tons of different versions of this. They don't all have to come from Furno. They're not all Pediamate, Neomate. There's tons of stuff. The takeaway being, you can't just throw kids in the ambulance and say, well, this is an emergency, so it's good to go. You cannot do that. You've got to manage kids safely. You're not absolved of that truth because the kid's experiencing an emergency. And yes, you can take the car seat. As long as the car seat is a DOT car seat, meaning that they didn't make it in their garage, and it is intact, meaning it suffered no visible damage and all the parts appear to be working as they should, then you're allowed to put that on your stretcher, secure it to your stretcher, and use it to safely transport that child. Sample no PQRST are the same. Are they on medications is the big deal. We already talked about the head, neck, chest assessment. Listening to lung sounds is much more difficult in kids, people. You're going to have to be on your game. They breathe really fast and they take really short breaths. So you got to really listen longer to get the same amount of familiarity with their lung sounds as you did in the adult population who's taken these big, big breaths. Remember that we breathe about 4 to 6 cc's per kg every breath. And so if I weigh 100 kgs, we're talking about 400 cc's of air movement. But if I weigh 7 kgs, we're talking about 280 cc's of movement. That's not a lot of air movement. We're talking about 150 cc's of air movement. That's not a lot of air movement. So keep that in mind. You got to listen to them much more closely and for longer periods of time to get the same tangible feel for those lung sounds as you did in the adult world. Vital signs, you got to know vital signs for that age group in order to know what you're looking at. Is it normal or is it not normal? Guys, I have this app on my phone. And it's going to have a lot of information that you don't damn need. That's just the truth. I'm sorry. But there is no app like this app that I have had. It's incredible. Now, if you go work at Berkeley County, which is an outstanding service, I mean that from the bottom of my heart, they bought Hantevi. And they give you a password to their Hantevi app. In the Hantevi app, you literally just put the Hantevi app in, I pull the Hantevi app up, and the first thing it gives me is a patient. I can say add new patient, and then I pick their age or I pick their weight, and what pops right up? Everything I want to know about them. Vital signs, the expectations of vital signs, medications, drips, equipment, anything I could possibly want to do to that kid, the Hantevi app is bam, right there on it. I hope you have something like that when you go to work there. If you don't, download this app called Critical. Critical is a red background with a white C on a black writing. It's about $15. It's worth $45, guaranteed. They update this app constantly, and you can go to pediatric patients just like the Hantevi app. You can click on their age. 1 year I clicked on, and bam, vital signs pop up, electrical dosages pop up, medications, equipment, ventilator settings, everything you could ever want. Bam, right there. I really suggest that for you. The idea that we could remember every freaking range group for kids is bullshit. We can't remember that stuff. Yeah, you got capillary refill, and that's great. You need it, and it's good. It's reliable in this population, but it feels real good to have a reliable resource that you can quickly pull up and say, this is where this kid should be, and here's where we're at. I suggest you go work somewhere that has something like that. Hantevi being probably one of the best versions. Here's a little test question about blood pressure. Now, this only works from kids age 1 to 10. I would argue that some studies show it doesn't really work greater than the age of 8. But nevertheless, it's here for you. 70 plus 2 times the age of the kid. And so if I've got a 6-year-old, that's 12. So 70 plus 12, I should be at least 82 systolic. I wouldn't want that kid anything less than 82. So let's say you get 80 and you're like, well, gosh, that's kind of close. What is your capillary refill? What is your capillary refill? If your capillary refill is 3 seconds and your systolic is 80 and it's right on the line, then it's not good enough because the capillary refill should not be delayed in a kid ever. Okay, keep that in mind. They love albuterol. They love epi. Just letting you know. And they've got the hearts to sustain it. So don't be afraid. If you think this kid's anaphylactic, you hit them with that epi. You think this kid's wheezing? Get them that albuterol. Children are sometimes on 30-minute, 1 hour, 3 hour nebulizers having constant flow of albuterol. They can sustain those medications very well. So never be afraid to hit a kid with a little albuterol. And if necessary, per your guidelines, never be afraid to hit them with some epi. They've got the hearts to sustain them. You've got to make sure they're ventilating. You guys know what to do for foreign body airway obstruction. 5 back slaps or 5 chest thrusts if they're an infant. If they're above the age of an infant, you got to find a way to do the abdominal thrust. Is my recommendation that you use the wall. The wall is your friend. It doesn't give way. We've talked a lot about that. If you can get behind them, get behind them. If you can't get behind them, pick them up. You got to find a way to get that abdominal thrust done. Asthma, they should be wheezing. Give them albuterol. Give them oxygen. Pneumonia, they'll have a fever. Give them oxygen. Croup, get ALS back up. And they're going to need some oxygen. We got to talk about croup and epiglottitis a little bit because you're probably like, well, now we might have mentioned this before. I'm going to mention it again. Croup and epiglottitis are very common respiratory emergencies. Upper respiratory emergencies. They're most commonly from parainfluenzal type things, virals, croup especially. Epiglottitis leans more on the bacterial side. You don't give a crap. The point is, these viruses or bacteria easily inflame the tissue around the hypopharynx and the glottic opening. And so they cause this raspy cough and this difficulty breathing that gets much worse at night. And so you're going to see test questions about croup and epiglottitis. Croup, the trigger word on the test for croup is sill bark-like cough. At night, they'll get this nasty, raspy cough, and it gets worse at night because you're starting to get sleepy and you're not protecting your airway as well, which is natural for a sleep process. And so then this cough starts coming and it gets worse and worse and worse. And this kid starts looking really in distress and they're making this horrible barking noise. And so it scares the crap out of these parents. They call us, and they should. And this kid's in trouble. So we want to give them oxygen. You want to keep them calm. The more they get upset, the worse their symptoms are going to become. So keep them calm, give them oxygen, get them in the truck, and get them to a paramedic. The paramedic's going to take epinephrine, put it in a few cc's of normal saline, put it in a nebulizer, shake that bad boy up, and we're going to give it to them. And they're going to be happy as a peach. Promise you. So there's that. Now, I think you guys should be able to do that, but that ain't come yet. You know I'm a little too aggressive for most flavors around this place. But eventually, I hope that you guys can make your own little neb of some epi. It's not hard to spot that these kids need this. They're super healthy to support that epinephrine. Yeah, it drives the crap out of their heart, but it clears that airway up like quickety split, my friends. So I think you need your ALS back up quick. Keep them calm. Give them oxygen. On the test, the primary trigger here is sill bark-like cough. This one is scary. This is a kid that if you get them upset, you get them breathing faster, you get that airway under more distress, it'll close on you. And that's it, ladies and gentlemen. They're dead. You don't want to play with epiglottitis. The trigger words for epiglottitis is drooling. Drooling. Here's a person who's got a bacterial infection of the epiglottis. It is getting fat and heavy, and they can't hold it off the top of the trachea. The gatekeeper becomes a killer. And so you're going to find them in tripod position sometimes, drooling. Why are they drooling? They don't want to swallow because it hurts so bad. That big old epiglottis hurts, and so they don't want to swallow. And so this is a patient you must keep calm. Give them oxygen to the best of your ability, but most importantly, emergently transport this kid to a pediatric ER so that they can take care of this airway. They need antibiotics fast, and if it's really ugly, they're going to need a cricothyrotomy of some sort, and that's limited in children less than the age of 12. You do not want to upset this kid because they'll close their airway and they will die right in front of your face. So I'd argue that epiglottitis is scarier than croup. That's not to say that these kids don't do well. They do. Kids get epiglottitis. They get on antibiotic treatments. They get on humidified oxygen with the little tents that you see in the hospitals. If you ever had a sick kid with an airway problem, you know what I'm talking about. And they do fine. The deal is keep them calm, spot it early, and, don't get crazy and ahead of yourself. If you can humidify the oxygen, great. If you can warm the oxygen, great. If not, fine. Give them the oxygen the best way that you can. Emergently transport. I don't know that ALS backup is going to be a big help here because these kids don't super respond to racemic epinephrine. Racemic epinephrine just basically means nebulized epinephrine. I'll just say that for you, even though a pharmacologist right now is probably dying. But it's not a big deal different from that. And so it doesn't really help these kids. It does, and then it doesn't. So ALS backup on epiglottitis is probably not the bang for your buck that it was on croup. Croup equals seal bark like cough. Epiglottitis equals drooling. I'm going to let you read those. OPAs and MPAs work just as good in children as they do in adults. You already know about oxygen delivery devices. I'll let you see the little cute ways they've come up with to give kids oxygen. We talked about shock in kids, anaphylaxis in kids. You are going to see a test question or two about AEIOU tips. Not hard. Kids get into stuff and they get altered. And the reasons for that is all over the place. Now, AEIOU TIPS is an acronym across the spectrum. It doesn't necessarily apply to children only. AEIOU TIPS is recommended in all populations, but definitely good here in children because children are just so unknown. If they're big enough to be moving around and getting into stuff, you don't know what the hell they got into. So, alcohol, epilepsy, seizuring, electrolyte stuff, insulin, opiates, kidney stuff is uremia, trauma and temperature, infection, poisoning, and shock. And then shock is all over the place. Guys, remember something. I've told you this before. I'm saying it again. People go into seizures for every emergency on the planet. If you can name an emergency that's going to kill you, one of the symptoms before you die will likely be seizure. You cannot get complacent with seizures. Seizures deserve respect. They deserve investigation. Hypoxia results in seizures. Hypoglycemia results in seizures. Hypo and hyperthermia result in seizures. Trauma results in seizures. You gotta worry why they're having a seizure. Now, if they're below the age of 6 and they've got 104-degree temperature, well, there you go. That's probably why. If their blood sugar is 20, well, there you go. That's probably why. If their SpO2 is 5, that's probably why. So you've got a reason, but you got to be thinking about why this kid's having a seizure beyond the idea that they might be neurologically epileptic, which might be the case, but you got to rule out a lot of stuff before you get to that. Remember, the management of a seizure, the focus of that management should be airway, airway, airway. You are going to see a few questions about meningitis. Meningitis is inflammation of the lining of the brain and spinal cord. It's characterized by nuchal rigidity. We said nuchal means neck. Nuchal rigidity. And so in nuchal cord, the cord was around the neck. In meningitis, nuchal rigidity is stiffness of the neck. So this person doesn't want to touch their chin to their chest. This person wants to be in the fetal position. They do not want you to extend them out. Why? Because the layers that protect the spinal cord and brain are inflamed. That's why. And they're also going to have, allegedly, some of them, these red, blotchy, rashy spots. That's characteristic of meningitis. Meningitis is very contagious, people. So wear your eye protection, wear your mask protection, wear your gowns and your gloves. If people have a big cough and their neck's stiff and a temperature and I can't touch my neck and my chin, my chest, I can't move my body out into an open position because it hurts me so bad, hurts my back, it hurts my chest. That scares me. I'm putting on my equipment. Guess when people find out they should have been protecting themselves? Typically after they've been exposed. Think about that. Appendicitis is common in children. Right lower quadrant abdominal pain. They'll be doubled over. They don't want you to move them. They look sick. Maybe they've had some vomiting. Maybe they have had fever. Rebound tenderness is very common. You push in and they're fine. You let go and they scream out in pain. I'll let you read that. Poor little kid. We be doing all kinds of crazy crap to kids. This is called tenting, and that would be a dehydration sign. Although this kid's probably not tenting because he looks very pink and he's upright with great tone. He's looking forward with his eyes, following people around. So they're just using the elasticity of a young child's head to prove a point. This kid, otherwise, by my pediatric assessment triangle purview, looks to be pretty stable. Fevers are anything above 100.4. We talked about febrile seizures. Kids that are in a body of water, you should really be concerned about their neck. Did they injure their spine? You can place kids in spine motion restriction, and you should. Long bone equals shock. When you break long bones, you bleed internally by great margin. In burns, the rule of nines is different in children. You learned that in the trauma section under the skin trauma, soft tissue injuries. The rule of nines is a little different in children. It accounts for that big head. Triage is different in children. There's going to be a little test question, potentially. The only difference in triage of children versus triage of adults. If I walk up to an adult in a mass casualty scenario and the adult is not breathing, I will open the airway. If they don't breathe, I categorize them as dead and I move on. In the start triage, jump start triage, we know that those kids are airway, airway, airway. So because they're so airway driven, if I walk up to a kid in a mass casualty incident that's not breathing, I will open the airway. If they do not begin to breathe, I will administer 5 rescue breaths and reassess. If they then aren't breathing, categorize them as dead and move along. That's the difference in jump triage. We already talked about that. Here's the child abuse mnemonic. Make sure you familiarize yourself a little bit. You don't have to memorize these mnemonics that I haven't put on the mnemonic list, but you should just have enough familiarity if you got a test question or two about them. So in this one, it's how to spot abuse, and it's inconsistent stories. So C is consistent with the injury based on the story. H, history of inconsistent injury. I, inappropriate parental concern. They don't want us to take the child to the hospital. That should concern the hell out of you. What good parent doesn't want you to take the kid to the hospital? L is a lack of supervision. That makes me think neglect, neglect, neglect. D, delay in seeking care. That happens a lot in abuse cases. Mom's new piece of crap boyfriend doesn't like the kid. Mom has to go to work because she's trying to make ends meet while this piece of crap sits on her couch and he's watching her kid today, and the kid won't shut up and leave him alone. And so he yanks the kid up by his arm and breaks the humerus. This stuff happens, guys. Mom comes home, oh, he fell down today and his arm's been hurting. Let's just reassess tomorrow. And you go a day or two without any intervention before mom realizes this child's freaking arm is broken. That's a big red flag. Delay in seeking care is a red flag. A is affect. There's a disconnect between mom and kid, or dad and kid, or caregiver and kid, or the other side of the fence. They're hovering over you. They don't really want you looking at the kid. B for bruises of various stages of healing. This is common to be looked at for children and for the geriatric population. You should not have bruises all over this baby's body in multiple stages of healing. Now, there are places where bruises are normal. On shins and knees and feet and arms, elbows, where kids are just constantly falling down and being kids. But you shouldn't see bruises across the back in multiple stages of healing. You shouldn't see bruises across a kid's chest in multiple stages of healing. You should not see, per South Carolina law, bruises across the butt of a kid in multiple stages of healing. You are not allowed to leave marks on children in this state. So if you see bruises in various stages of healing that aren't on the arms and legs where the typical trips and falls and the normality of kids occur, it's worth mentioning. Now, you don't go putting any of your diagnoses in your narrative. I think mom's beating the hell out of this kid. Don't put stuff like that in your narrative. You say what you found. I found bruises across the back, lower back of this child in multiple stages of healing, and I reported that information to the receiving facility. Just that simple. Objective. U, unusual injuries. S, suspicious. And E, environmental clues, like not having any food in the house. If a kid is unconscious without obvious reason, it is a crime until proven otherwise. If you don't know this, if a child presents to the emergency room and they are not conscious or semi-conscious, and we don't know an immediate cause, like external trauma, those parents are immediately placed under investigation. That's called altered mental status of an unknown etiology, and in children, that is a crime unless proven otherwise. Why? Because kids don't just suddenly go unconscious. I'll tell you how you can get a kid to go unconscious. Shake the crap out of them. And people think we can't see that on brain scans, but we can. Petechial hemorrhaging is in the eyes of this patient. We can see that. Little hemorrhages across the gray and white matter of the cerebrum. We can see that. If children are unconscious with an unknown etiology, which means unknown cause, it's a crime until proven otherwise. I'll let you read about SIDS. Don't work dead babies. If they're dead and it's obvious that they're dead, they're just as dead as if an adult was dead. Don't try to work dead babies. Follow your guidelines. I'm going to let you read about that. ALTI, I will touch on. ALTI is a big event that we miss a lot. You get called to a not breathing baby. You get there, and this baby's pink and beautiful and crying and all happy and pissed off. And you're like, what the hell did you call us for? And mom and dad or caregiver, grandmama, granddaddy, or whoever the heck gives us this story about the kid suddenly becoming unconscious. We're talking about 1-year-old, 2-year-old. We're talking about 45 days old, 6 months old. We were trying to feed him, and suddenly he turned blue and went unconscious and kind of started shaking his mouth and face, and in a couple of seconds it fully resolved. That ain't okay. That's called an ALTI. Don't get confused by the fact that this kid now looks great. You aren't allowed to have an event as a 6-month-old while feeding where you suddenly have a change in consciousness and look like you're freaking dying, and now you look okay. That's especially true, kids, in 3-day-olds, 4-day-olds, 5-day-olds. Let me tell you something. Children that are born with congenital defects do not always present as such in the nursery after being born. Sometimes those kids get sent home with congenital defects. They have a hole in their heart. They have incorrect pulmonary and cardiothoracic anatomy. And so they go home and they experience these alties. And if ignored, we will miss a life-threatening congenital defect. Alties are considered emergencies until everything that could possibly have caused it is ruled out by a board-certified pediatric physician. Take Altie children to the hospital. Advise parents that Alties are a potential precursor to death in children. Make them aware of the unstableness of Altie. Here we go. Question number 1. Agree? Child falls from a significant height. The blank most often hits the ground first. Same answer. The head. The head is bigger. So they're more susceptible to brain injury. When assessing a conscious and alert 9-year-old, you should They're 9 years old. Why can't they answer their own damn questions? The parents can help them, but 9-year-olds should be outgoing and vivacious, and they should want to interact with you and tell you their history and you their information. That's a really positive sign. Let children interact with the assessment as much as possible. We didn't talk about this, guys, but AV shunts, atrioventricular shunts, or shunts that empty out into the peritoneal space. When kids have fluid balance problems in the head or constant ear infections, we'll put in these shunts that help equalize pressure and fluid from the head, and they do so by moving that trapped air and trapped excess fluid back into the peritoneal space or the chest space. Those can become clogged, basically. They can become occluded, and when they do, they present a certain way. Extreme altered mental status, seizure, fever is a big one. Severe headache is a big one. The purpose of these shunts is to minimize excess fluid and pressure in the head. So A is the answer here. And so ventriculoperitoneal shunting is simply the anatomy. We take it from the cranial ventricular space and pop it into the peritoneal space. That's what most people's bodies are already doing. But some kids don't do it well, and so they get these VP shunts. Call them AVP shunts. Which of the following is true about febrile seizures? And the answer is D. And we went over that a couple times. Febrile seizures last very short in duration, and they are not normally confused after. Although I think this question is misleading as hell, because when kids have febrile seizures, they already don't feel well. When they recover from the seizure, they're very lethargic. And for the book to not think that lethargic and lethargy and obtunded presentation isn't a postictal presentation is odd to me. But what they basically mean is that if a 5-year-old has a febrile seizure, they will come back to able to answer their questions. You will just have to kind of get them to answer you because they're sleepy, they're tired, and they feel bad. And so I don't like this question. I've always felt that it's inappropriately formed. Postictal means alteration of mentation, and these kids do come back to you much more lethargic, much more apprehensive to participate in your exam. I don't like this freaking question. You respond to sick child at night, very ill, there's fever and drooling. What's the problem? Epiglottitis. Semi-conscious child swallowed an unknown pill. What do you want to do for that? Semi-conscious child swallowed an unknown pill. Yeah, I like B. If you thought A is contraindicated because the kid's unconscious to semi-conscious. You can't put crap in their mouth, especially not activated charcoal. So B is a great answer. B covers everything good, so I like it a lot. When using child abuse mnemonic, the D stands for... B has always been a funny answer to me. Some people do legitimately think that children will have negative impacts simply because their parents divorce. You've lost your minds. You're not reading the data, you opinionated a-holes. Divorced children can be successful. It doesn't stand for that. It stands for delay in seeking care. Very good, Jen Hernandez. Delay in seeking care is a trigger, a flag for I'm being abused. 4-year-old girl fell from second-story balcony, landed on her head. She's unresponsive. Slow, irregular breathing, big bruise on the head, bleeding from the nose. You should. Very good, Jen. C is right all day long. It follows the sheet perfectly. It literally follows the sheet verbatim. This is a trauma patient. So you've got to think about C-spine. Opening the airway with a jaw thrust is appropriate for trauma. Adjunct is always going to make you better at positive pressure ventilation. Assist that ventilation because it's irregular and slow, and the patient is unconscious, unresponsive. C is a beautiful answer for that question. Whew. AVPU, the P stands for pain. You guys know that. All right. Take a quick 5-minute break. Let's come back at 9:10. 9:10, and we will close this thing up. let's close up shop. Throw your hands in the air, wave like you don't care if you're still with me. And you couldn't be more sad than I. We're still going at it. Trust and believe. That's 12. If that's Vishnu I'm waiting on. Mighty Doll, you should be ashamed of yourself. You're one of the good ones. Just kidding, Vishnu. You're always good. Alright, let's carry on. We're going to do chapter 36. Thanks, Maddie. A little late to the party, but you're here. Geriatric emergencies. Let's summarize this chapter. The Gems Diamond, polypharmacy, slowing and malfunctioning of organs and organ systems, stable applies to them just like PEDS. So let's go through it. Geriatric patients present to EMS tons of times from the emergencies that have already existed in their life. Progressions of, or as we call them, exacerbations of the things you would have discovered in a quality sample and OPQRST. What medications are you on? What pertinent medical history do you have? Tell me about yourself. You have any drinking or alcohol, drugs? Do you take lots of medications? Polypharmacy is the term we use for the fact that geriatric patients are on a medication for everything. And those medications don't like each other. And so this medication causes that medication to do bad things. Example, there's a blood thinner called Coumadin that a lot of geriatric patients are on because as we get older, we clot too much. And so that causes strokes and heart attacks and deep vein thromboses. And so we put a bunch of geriatric patients on Coumadin. Well, Coumadin doesn't play with Pepto-Bismol. As little as going to the pharmacy and grabbing yourself a little Pepto-Bismol might put you in an emergency. So all those medications become a problem. They don't mix well. So that's polypharmacy. They get on a bunch of pain medications. Pain medications cause elderly patients to be constipated. And so then that's how they present to us. Polypharmacy. The Gems Diamond says that we should take into account, my screen just flashed, so if you're still with me, put your hands up. Okay, good. Lord knows I would cry if I just talked for an hour and you guys weren't here. The Gems Diamond says we take into account the geriatric environment, medical assessment with all of the ideas of this is a geriatric patient, and the social well-being of geriatric patients. Who checks on you? Who takes care of you? Do you have a home caregiver? Do you have family that comes and checks on you? Do you live alone or do you live in an assisted facility? Do you live in a nursing home? Do you have people who help you take your medicines, get your mail, cook, clean, check after yourself? Remember that we call those things activities of daily living. When you assess a geriatric patient, you also have to think about their environment. Did you walk into the house and the stove was on? That's a problem. Did you walk into the house and it smells like urine? So the patient hasn't been able to get to the bathroom. They haven't been making it to the bathroom, so they've been peeing on themselves or peeing on the furniture. That's stuff that we find all the time, and that stuff suggests that the patient is progressing in a state in which they need more care from outside providers than they are receiving. Remember my grandmother's statement, we are once an adult in this life, but twice a child. When we were very young, we needed a lot of people to ensure that we were safe and that the ingredients of a good life were intact. Food, shelter, clothes, safety, watching after. We need that in the geriatric population too. The environmental component of the GEMS diamond and the social component of the GEMS diamond help us to account for the fact that these people are independent and they're adults. However, are they getting the care that they need? Are they being checked after the way they should be checked after? Is anyone making up the difference? The book is going to say that we don't assume, and we don't. Not all geriatric patients are the same. Some will go their entire lives not needing to be looked after. There are 96-year-old people sharper than me and you. We can't assume. But we also know the commonality that the environment of a geriatric patient matters to their mortality and to their illness. It matters that their social components are intact. Are you getting out of the house? Do you go to the senior citizen center? Do you see people? Are you going to your church groups? Are you going to your friend gatherings? Are people coming to look after you? Can you get to the phone if you needed it? Can you get out of this house if it caught on fire? Those are the things we've got to take into account when we think about geriatric people. And we are legally obligated to consider the GEMS diamond. Slowing and malfunctioning of the organs. The book is going to go into detail about how the brain actually gets smaller in its organic form as we age. I apologize. It's going to say that the heart and lungs are not as efficient and capable of their job as we get older. The lungs lose elasticity, so their ability to ventilate and respirate effectively diminishes. And so that VQ ratio becomes 1 to 1.2, 1 to 1.5. That's not what we're expecting. It's supposed to be 1 to 1. For every ventilation, there's an immediate and effective respiration. As we get older, simply by the aging of our brain, heart, lungs, and kidneys, and liver and spleen, we're less effective at doing the job. One of the big areas that we see this in is in the polypharmacy area. In polypharmacy, another big problem that these patients have, secondary to the slowing and malfunctioning of organs due to the aging process, is that they cannot eliminate medications very well. So if you give an 80-year-old woman with hepatic slowing the same dose of a given medication that you gave a 35-year-old, it is likely that that same dose will stay in that geriatric patient's body longer and fail to eliminate effectively before the next dose. So we have to kind of stretch out the dosages of medications in the geriatric population based on the lab value results of their hepatic and liver function. Are they able to clear these medications out effectively? If not, we've got to change the dosing and frequency that we send these patients home with medications for. Again, very susceptible to abuse and neglect. Again, the acronym STABLE is very reliable as to fixing emergencies in the population. What is their sugar? What is their temperature? Keep them warm. Their skin has thinned. They're unable to warm themselves like you and I are able to warm ourselves. They easily have skin tears. If you let the elbows of the geriatric patient come out on your stretcher and you whack them on a wall, it is going to immediately result in a skin tear that will not heal very well. It will take forever to heal up, and that person is going to deal with that skin tear that you gave them simply by not observing where they were on the stretcher versus how we're moving them in the house. That's why we tell people to give themselves a hug. That's why we tell people to not let their arms come out of the edge of the stretcher, because we're going to bang them on something. And it's a big deal, folks. A lot of them are taking blood thinners. So you're going to cause bruising and you're going to cause skin integrity breakdown that's going to last them a month. Be very, very cognizant of this in the geriatric population. They don't warm themselves well and their skin is very, very brittle. And they're constantly on blood thinners. Okay? I want to remind you that geriatric patients are very susceptible to intracranial bleeding because they take blood thinners. When elderly patients fall down and they are on blood thinners, it takes near to nothing for a little vessel in their head to start bleeding. Don't ever get comfortable recommending elderly patients stay home after a fall from their standing height, if they say they struck their head. You won't ever find me recommending or even comfortably conducting a refusal on an elderly patient who's on blood thinners if they tell me they hit their head. I don't care how light it was. I don't care that there's no trauma that I can visibly see. I've seen it too many times. Ladies and gentlemen, the number one flight at Medicare Air every single month for the 7 years that I have flown there has been and remains to be intracranial hemorrhage in patient populations above the age of 55. It is still the number one thing we fly. That's how often it's happening. If geriatric patients are taking blood thinners and they fall down, recommend that they go to the hospital. It's just too much of a risk to bear. Stable. What's the sugar? What's the temperature? Is airway stable? Are you accounting for it? Put them on oxygen. What is their blood pressure? It's easier to detect in this population. Now, capillary refill is not very reliable in the elderly because they've got vascular aging. They've got vascular disease in their history. They've got this brittle skin. They don't have as fast a responsive tank and pump as that 16-year-old we talked about earlier. So you can't really use capillary refill as well in this population, but you can use blood pressure because you know that. I want to remind you that these people are on blood pressure medications that prevent them from showing tachycardia. So when geriatric patients are in trauma, they'll have a heart rate of 80 and you'll slap your friend on the back and say, they're okay. They're not even showing signs of shock. They can't show signs of shock, you idiot. They have a medication that prevents their heart rate from raising. The blood pressure medications that we give people prevent high blood pressure by lowering the heart rate. So you got to be a little careful when you assess these patients and you say, well, they're not really showing any signs of shock. You might want to ask yourself if they're on a medication that prevents them from showing signs of shock. That's the geriatric chapter in a synopsis. Let's run through real quick and see if we missed anything. Abuse and neglect, we talked about that. The Jim's Diamond, we talked about that. This is the changing and aging of the body that we discussed about, the common sample findings that you'll have. You know what a pulmonary embolus is. We talked about their lungs not being as elastic. You do need to know the word atherosclerosis, which means as we age and we continue to eat fried chicken, because God knows I love fried chicken and biscuits, and I ain't giving it up. It ain't worth living if I don't have it. So I'm going to move right on with my Starbucks, my fried chicken, and my biscuits nonetheless. And we're going to develop over time some clogged ass arteries. And here they are, clogged on up. That's atherosclerosis. Atherosclerosis leads to DVTs, deep vein thromboses, which tend to happen in the legs, heart attacks, and strokes. That's what atherosclerosis leads to. You know what that word means? You guys know about heart attacks? Heart failure. You're going to see some test questions about whether it's right-sided or left-sided. I've already addressed this in the medical chapter, but I'm going to remind you again. If it's right-sided failure, then it would back up where the blood was received. The right side of the heart receives its blood from the periphery, and so then the fluid backs up in the periphery. If you look at an 80-year-old's ankles and they look like cankles because they've got fluid all the way up to their knees, that's right-sided heart failure until you prove otherwise. The fluid backs up from where it came. The right side of the heart receives its fluid from the periphery, so that's where it backs up. The left side of the heart receives its fluid from the lungs. It gets blood back to the left side of the heart from the lungs. And so then that's where it will back up. Left side of heart failure causes pulmonary edema. A simple test question, I think, but if you don't know the blood flow of the heart, it ain't going to be easy for you. Pay attention to that. Paroxysmal nocturnal dyspnea. Those are $9 words for intermittently when I lay down at night, I can't sleep because I have trouble breathing. What that's caused by is that buildup of fluid in their lungs. And when they lay flat, that fluid covers more alveoli and prevents them from oxygenating. And so then they get more and more and more dyspneic. Paroxysmal means it comes and goes. Nocturnal means it happens at night. And dyspnea means I'm trouble breathing. And we've talked about that a lot. Lung sounds that you're going to hear for that are rales and the bases before the apices. And you need to give them CPAP at 5, 7.5, or 10. Talked about that a lot. Hemorrhagic stroke versus occlusive stroke. We've talked about that a lot. We talked about subdural bleeds, which are typically venous, and they take a long time to progress, so the patient may look okay, but they won't be in a few hours. And then we've talked about epidural bleeds, which aren't common in old people, but epidural bleeds are arterial, and the patient gets knocked out, but they come right back to, and when you get there, everyone thinks everyone looks fine. Everything's okay. And then they go to sleep and they never wake up again. That's why old people used to say, don't let anyone who hit their head go to sleep. They were talking about epidural bleeds. Know the difference when you read the chapter. Remind yourself about our previous conversations and your previous reading about the difference between subdural hematoma and epidural hematoma. Bleeding in the brain. Is it slow and venous, or is it fast and arterial? Those look different. Osteoporosis is the breakdown of the bones, so they get fractures more easily than you and I. Neuropathy is a breakdown of the peripheral nervous system, so they don't feel pain as fast as you and I. So what the book is going to say is that they are susceptible to more injury from the same exact mechanism than you or I, because they might leave their hand on the stove longer than me and you. Our body might have said, whoop, that's hot, get back. But it'll take that message in their body much longer to be received by the brain, and so therefore greater injury occurs. The gastrointestinal system slows down. They don't pee as well. They have to go on dialysis. We've talked a lot about dialysis. Polypharmacy. They're much more susceptible to suicide. The Jim's Diamond we covered. We talked about trauma mechanism considerations for elderly people and how they might hide their symptoms of compensation. Responding to nursing skilled facilities, start from zero, folks. Don't you get to the nursing home and think those people know what the hell they're talking about. I ain't found one that does yet, and I've been doing this for 15 years, and I will not hold my tongue. Every time we go there, it's jacked up. Don't walk up in there thinking that the patient's already received the care they need. You start from zero. Assess the patient for yourself. If you walk in the door and they tell you the glucose is 120, get yourself a glucose. The least common cause of death in patients over the age of 65 is drug overdose, because that ain't what the chapter is discussing. Stroke, common in old people. Diabetes, common in old people. Heart attack, common in old people. 90-year-old people aren't behind the dumpster in the Family Dollar shooting up heroin. It just doesn't happen. So D is not the problem. Why? Because you died long before you got old. According to the Jim's Diamond, a person's activities of daily living are evaluated in which part of Jim's? Which part of Jim's do you assess activities of daily living? Come on, people. Wake up. In the social. Yes, very good. A condition that clouds the lens of the eye. This is easy. Cataract, not glaucoma, whole different thing. You are called to a neatly kept residence of an 80-year-old woman who is spunky. She lives by herself and she's burned her hand on the stove and experienced a full thickness burn. When treating this patient, it's important for you to remember what? Yeah, D. Their periphery neuropathy. That's what the cause is. slow onset progression of disorientation, shortened attention span, and loss of cognition. We've gone over this before. The slow onset and progression. Which one? B or C? Bravo or Charlie? Slow and chronic is dementia. Delirium is acute aggressive in the now. It's right now and it's bad. I would associate delirium with a cocaine overdose. I would associate dementia with the elderly. 71-year-old patient with a history of high blood pressure has a blood pressure that's low now and a fast heartbeat and fast breathing with an abdomen that's rigid and distended. You should be concerned for what? And the answer here, I already gave you because I'm fast clicking, is A. I would be concerned of an aneurysm. If I have a vascular disease patient, history of high blood pressure, and they have an abdomen that's rigid and distended, I'm thinking about the great vessels. That heart rate is what's going to get them in trouble. We need to reduce that. That's why you need ALS backup. We can give a medication to bring that down. Every time they hit that aneurysm, bam, 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 bam. There's more of the chance that that thing's going to rupture and give way, and then it's all over, folks. So if we can reduce that number, the patient gets better. We do that with a medication called esmolol. Esmolol. Which of the following is a psychological, let's go, physiologic change that occurs in the process of aging? So which one of these things physically happens to people because of aging? C. Kidneys decline. Everything declines. Everything gets smaller. Everything declines. Which of the following conditions make the elderly prone to fractures? B to the bravo, that osteoporosis. Polypharmacy is used to prescribe medications of all kinds to the elderly. They take too much crap. Inflicted bruises are commonly found in all the following areas except. I hate this question. I staunchly disagree with them. They say that commonly assaultive bruises are not found, they say, in the forearms. I disagree with them. And here's why. Elderly people are not dead in the bed. If you try to beat on them, they will naturally try to protect themselves. And defensive wounds are a common finding in autopsy, and it's certainly a common finding in the investigation of abuse. People don't let you just beat on them. They try to protect themselves from the blows. So I disagree with this stupid question for the reasons I said. It would make way more sense to me that inflicted bruises wouldn't be found on the inner thighs because the inner thighs are super protected. So unless you're considering a sexual abuse, the inner thigh wouldn't necessarily be a striking point. Most abuse that occurs to the elderly folks is simply from, statistically has been associated with the frustration felt by caregivers of the actual demand of the work it takes to take care of old people. It's quite daunting, even for family members. And so when you think of abuse about that, I want you to have that concept in your head because it'll help you spot that kind of abuse. This question is idiotic, and I would tell that to the face of the person that invented it at the National Register. They should be ashamed of themselves. Okay, let's quickly do Chapter 37. Patients with special challenges. Basically, we're talking about people that are at home with special equipment or special conditions in which they have caregivers whom you can rely on to tell you about those patients. So we'll quickly go through this and I'll tell you what you're going to be seeing from the test questions. We're going to go through quickly. This is talking about the patients that I just gave you. All the homeless people, they're in special conditions. The at-risk people, poverty, bariatric people. We're talking about ventilated people, tracheostomy people, which we know not to fear because tracheostomies are good. They go directly to the trachea. The biggest problem with tracheostomies is that they get all clogged up from mucus. So The caregivers at home can help you try to mitigate that. If they're calling you, though, I just want to give you a heads up. They've done all the things they know to do, and they're probably more familiar with that airway type than you are. So if they've done all the things they can do and it didn't work, let's get the hell out of here and get to the hospital and see if they can troubleshoot it with a little more intensive care. So think about that. We'll talk about some special things like spinal bifida, CP, cerebral palsy. We'll talk about some of those kids as well. Intellectual disabilities, kind of figure out from the family what is normal for them. That's the big takeaway here. Autism is, in my opinion, incredible and really beautiful, and a lot goes into autism. You can have very high functioning autistic people, and you have very low functioning autistic people. You've really got to dabble in with the family as to what is normal, why are we here, and it's not great when EMS gets called to autism. We don't typically bring a lot of solutions, especially not with law enforcement. They don't have very good history with taking care of special needs, nor do we in EMS, really. We don't understand this stuff very well. It doesn't respond to immediate gratification intervention. It takes time and talking and learning from family, and people just don't spend that time. Autism is when people are having a spectrum interpretation issue for which they cannot express to you. And I don't know what could be more frustrating than me being as smart as you, knowing everything that you know, trying to talk to you like you're talking to me, trying to tell you what the questions are that you're asking me. I've got the answers, and I can't get any of that out of me. That must be incredibly frustrating, and that is why these autistic children act so aggressively and so violently. There are a lot of Netflix documentaries on autism that will blow your freaking mind, and if you have a moment, go take a look at them. I will I will group me you guys, my favorite one, later, and you can go look at it. It's an incredible look at some of the most successful things they've had with autism that comes down to one consistent issue. They know what's going on with them. They can't express it to you. They cannot speak those words to you. They cannot use their body language to communicate with you. And that is incredibly frustrating. I won't go into any of the other stuff of autism, like what caused it or blah, 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 blah. We don't care about that crap. What we do want to do is take the information the parents know. What works? What do they not like? It is common for autistic children to not like loud noises. It is common for autistic children to stand on their toes. Don't stop them from doing that. This is not a time for us to correct their daily bad behavior. This is the time for us to do just enough to provide them the encouragement to get in the ambulance and go to the hospital safely without us having to get into a full-on fight. That's what our goal is here. So if they don't like loud noises, typically the parents will have a headset, a noise-canceling headset. That's very common for these kids. Get it. Put it on them. They sometimes have helmets. They sometimes have social comfort things like I have this particular autistic kid that I know of that likes to have one of those plastic Walmart bags in between his fingers, and he'll just rub the bag. And if he's rubbing the bag, everyone doesn't get their ass kicked. So guess what I give him? The daggum bag. And we got in the ambulance and we left. So whatever that thing is that these kids need, you're not going to be able to use the same verbal judo that you would with a drunk guy or with a psychiatric patient as you are with these kids. They're in a whole different world, and your best bet is to slow down and talk to family and recognize how incredibly frustrating it must be for them to have all the answers to what you're trying to get out of them, but they cannot express those things to you. If you don't have a heart for that, I just don't know why you're in this business. So take your time with these kids. The last thing you want to do is get into a physical encounter with them because their heart rates are going to go through the roof, their temperature is going to go through the roof, their breathing is going to go through the roof. The trauma that you are encountering with that patient now and what you are instilling into their already very vulnerable brain cannot be measured. So try your best not to get into physical altercations or even worse, chemical sedation encounters with these patients. It may not always be avoidable, but we should try. There's going to be a lot of Down syndrome questions. These are incredible kids. Again, some very high functioning, some very low. Some Down syndrome folks go on to live absolutely normal lives, and a lot of them don't. So it depends again on your ability to interact with the family. What's normal for this person? What you need to know is they're very difficult to ventilate. They have very large occipits and rounded facial structures, and their tongues are very large, and that makes them difficult to ventilate. My recommendation to you is, if they don't have a gag, get the King or the iGel in as quickly as possible so that you can overcome that additional challenge with Down syndrome kids. Some of this stuff is really obvious, and I'm not wasting my time on it. Again, this is a stupid slide. Do not give ASL your best go. That is so incredibly insulting, in my opinion. Get a family member, someone who does know ASL, to help you out. Or, they're not stupid. Break out a way to write. Most iPhones have a writing feature in Notes. They have a texting feature that you can use. There's tons of ways to communicate with the deaf, and you don't have to give sign language your best go from a Google search. If people have special equipment, bring it with them. You need to know what each one of these weird little things are that you may have never heard of, like spina bifida, cerebral palsy. You may have never heard of those things. You need to know what they mean very basically, because you might see a test question that simply just wants to see if you know what spina bifida is. Okay? CP kids are kind of all over the place. A lot of these kids do very well. Some of them, well, a lot of them don't do very well. And so a lot of the CP is from anoxic injury. And so what you see is what it'll always be. It doesn't get better. I do know CP kids that look like every other kid, and they are smart and they do well in school. And so it all depends on how anoxic that brain got. And there's no way to predict that. You just have what you have. And so again, talk to family. What is their normal? This is spina bifida, and these kids die quite quickly. They don't live very long. We do have interventions to do, but depending on the amount of bifida, they do die. I'm not going to read that to you because you can do the reading. It's quite obvious. I am definitely not touching on that slide because it'll get me in trouble. Tracheostomy tubes. The family knows about the tracheostomy tube. They wouldn't have called you if it was going well. So go ahead and get on packaging and get the hell out of there, because if family can't fix it, they have even the ability to put in a new one. When families go home, when patients go home on trachs, they train the family to care for the trach. If they're calling you about the trach, it ain't going well. Just get ready to go. If they're on a home automatic ventilator, bring the batteries, bring the ventilator. You can transport a patient on a ventilator. That is within the EMT scope, provided that you don't have to change anything on the ventilator. And I hear medics say all the time that that's not true. And so I bring you back to the source of all of where you should be checking your scope. And it's the South Carolina EMT approved skill list. And on the handy dandy South Carolina EMT approved skill list, you're going to see the ventilator. Ventilator, automatic or digital, by biad or stoma, with no other interventions. Cha-ching! The EMT. You don't need a freaking medic for that. Now, if it's A transport ventilator with an endotracheal tube that has to be in a medic, because we would have placed that endotracheal tube. But it doesn't have to be a medic if it's a ventilator that's the patient's normal ventilator, or even that we put them on a ventilator and you don't have to make any changes. So if that ventilator is hooked up, for example, to a tracheostomy that's already well established, that can be taken by an EMT. So if people tell you that it can't, it can. A trachea tube or a tracheostomy tube change out can only be done by a paramedic. If the family asks you to change out the tracheostomy, you're going to have to say a big fat no thanks. We don't know how to do that. So then don't give it your best go. The same is true for G-tube, gastric tubes. Families constantly ask us to put those back in. That's not even a paramedic skill. Why? Because you have to image it. You have to take radiological images to prove that you got it back in the right spot. You can't do that outside the hospital, so then it has to be done inside the hospital. Don't try to put these tubes back. Go to the hospital. This is a tracheostomy tube. I would like for you to look at the pictures provided in this particular chapter because they're a little bit special. It gives you familiarity. This is like a number 4, number 5 trach tube, and very common. Very common. How do you know if the trachea tube is displaced? Or if any advanced airway is displaced? Dope pneumonic is how. Is it displaced or dislodged? Is it obstructed by mucus most commonly? Do they now have a pneumothorax because of a ventilator or overventilation by positive pressure? That's common. If we've been bagging the crap out of them, maybe they popped a lung. So in the dope pneumonic, I'd listen to lung sounds. And then E is equipment failure. Maybe the actual piece of equipment in their throat is not working. The balloon on the end of it has deflated or popped. That balloon right there. Or the device is now so clogged and damaged that you can't use it anymore. That's how you determine if the trach should be kept or removed. And that's true for an endotracheal tube. It's also true for a BIAD, blind insertion airway device, like a King tube or an iGel. We already talked about mechanical ventilators. You're not going to see a lot of this, but left ventricular assist devices or LVADs. I'm not going to really... this is a tough conversation to have at the EMT level. You guys will get a little bit more of this when you go work somewhere. Basically, people that are in bad heart failure can sometimes have a pump put into the left ventricle, which is crazy, and it changes things. They don't have a pulse, so that's weird. That could present some problems. So how do you assess the patient? Well, you can put them on the monitor. Their rhythm is still detectable. You can take a non-invasive blood pressure, so that's helpful. You can put them on end tidal CO2. If you have carbon dioxide showing between 35 and 45, then you do have a good blood pressure because you could not be respirating without good perfusion. So then if we measure respirating by carbon dioxide, then the first thing you should do to an LVAD patient is put them on end tidal CO2. So if this machine is running, you put your stethoscope over the heart and you hear it humming, me. Okay, well, it's working. That's a good sign. Are they conscious or unconscious? And if they're unconscious, then it becomes kind of difficult because you can't check a pulse. Are they breathing? If they're breathing, then that helps. They're probably alive. Get them on the stretcher and get the hell out of there. Here's the good thing. On an LVAD, it has a 1-800 number on it. And it says, EMS, ? Call this number. I recommend you call that number because on the other end is a paramedic or a nurse specifically knowledgeable to that patient and that device who can help you work through an assessment and determine some pretty quick measures of trying to save this patient's life. The most common things that happen to LVAD patients are arrhythmias, lethal and non-lethal, low blood sugar, and low volume. You can imagine that if the patient became dehydrated, the pump would immediately start to fail because there's not enough volume in it. That's as far as I'm going to go with LVADs. A very complex conversation to a very complex patient that needs to be handled by ALS backup. LVAD patient, if you get sent to one, call for ALS backup. These are common in some of our patients. Be careful where you're putting your seatbelts. You might be about to pull out a line. People have G-tubes in their belly. People have colostomy bags on their belly. People have central venous catheters plugged into their left and right clavicles. Don't be throwing seatbelts around people not paying attention. You gotta pay attention to what you're doing. You might yank out a central line, and I'm gonna tell you, if you do, you're in a world of trouble because it's very difficult to stop subclavian venous access bleeding. That ain't easy. So you don't want to yank one of these bad boys out. The only thing you need to know about this is leave it alone. Is it dry and intact, the bandage? And does it look dirty? Because these are a very high chance of infection. If you went to a patient with an altered mental status and a grade of 104 fever and they've got a central line, I bet that central line is why they're in trouble. They're septic. I'll let you look at G-tubes. We already talked about it. We already talked about VP shunts. I'll let you look at colostomies. Be careful what you're doing with seatbelts. Don't pull out a colostomy. That's very embarrassing, and the patient will never forgive you. Here we go. Which of the following is a developmental disorder characterized by impaired social interaction? And the answer is autism. They are not dumb. They are not stupid. They know what's going on. Don't you forget that. Known risk factors to Down syndrome include, well, the answer is yes, increased maternal age. Very good, Leslie. Smoking can be. Traumatic brain injury at birth is not related to Down syndrome because it is genetically hereditary, and lack of vitamin B is not backed by data. The book is clear that it's Charlie. Increased maternal age. We don't really know a lot about that except that it is a chromosomal disorder. Does anyone know which chromosome it is? Does anyone have Down syndrome family? Yeah, very good. Very good. Very interesting set of patients. I just love them. Love them, love them, love them. A lot of them still live with their parents, and they always will. So talk to family as to what is the norm of those patients. Which of the following may be difficult to perform on a patient with Down syndrome? We talked about what their challenge is, and their challenge is airway. So then intubation will probably be difficult on them. So just be prepared for that. If we're going to RSI a patient with Down syndrome and put them to sleep, we might have trouble intubating, and so then we would need a supraglottic airway. And so then that would mean you should be ready to put in a king tube. Most patients with this disease also have hydrocephalus. The answer to that is Charlie. Spina bifida patients also have water on the brain. That's what that is. Water on the brain. These patients are tough guys, and unfortunately they don't live very long. What does dope mnemonic help you recognize? And the answer is potentially an obstruction of a trach, a biad, or an intubation. Displacement, obstruction, pneumothorax, and equipment failure. That's dope. What device is placed directly in the stomach to feed patients? A gastrostomy tube, a G tube. So if they can't eat by mouth for a multitude of reasons, they get a G tube. What do vagal nerve stimulators do? The answer is A and C. They keep seizures from occurring and thereby potentially have an alternate treatment than the medications like Keppra, Depakote, Dilantin. Important part of your assessment process with a patient on special needs is to what? I've said it a million times in this lecture as well as with PEDS and the geriatric population, and that is talk to family. Thank you, Dylan. Thank you, Leslie. What improves a patient's quality of life shortly before death? We know that the answer to this is comfort care. It's Charlie. Now, some of you are probably saying B because B is a type of comfort care. But remember, we go for the most global, most true answer. So hospice is just one version of